شكرا جزيلا أخي الحبيب. We have finished now the session UK experience in trauma, and then we come to the last session in our webinar, which is a unique session, unique gathering of eminent stars in one session, the lower limb trauma session. Our first speaker will be the hallmark of trauma in Egypt, Professor Osama farouk. دكتور أسامة فاروق طبعا هو من هو، يعني مش محتاج تعريف، يعني Professor of Orthopedic Surgery, Asyut University, one of the eminent stars in AO and the hallmark of trauma in Egypt. Professor Osama, please, sir.
Thank you very much, Professor Mohamed Al-Ashhab, for introducing me. I attended most of the talks today and enjoyed them very much. Now we will move to talk about the fragility fractures of the pelvis. First of all, I would like to thank my dear friend, Professor Mohamed Al-Ashhab, for organizing and moderating this very interesting international trauma webinar, including more than 50 speakers from 4 countries. Thank you, Professor Al-Ashhab. My deep thanks and appreciation. This female patient, a diabetic patient, 73 years old, presented with painful right hip region. We did plain X-ray and CT scan that showed this in place fracture of the pubic ramy and right sacral fracture. I think most of us will take a decision to apply a conservative treatment in this lady and give her medical treatment for pain and for osteoporosis. 6 weeks later, the patient presented with pain, deterioration of mobility. We did again plain X-ray, CT scan that showed progression of the fracture. So we are going to define the specific characteristics of fragility fractures of the pelvis, and we will ask ourselves, do we need to have a classification of pelvic fragility fractures, and how can we apply this classification? We are going to outline the different treatment options and describe the outcomes expected after pelvic fragility fractures. Pelvic fragility fractures is going to increase worldwide. 7% of all osteoporosis-related fractures are now pelvic fragility fractures in people over 50 years. The average age of patients with low energy pelvic fractures is around 70. It is 69 years. It is expected to increase by 60 to 100% by 2030. So we are facing more and more cases with pelvic fragility fractures. What are our concerns when we face a case with pelvic fragility fractures? The cavernous bone corridors, this will make the fracture reduction as a difficult task. We have as well the limited fixation opportunities in such quality of bone. Moreover, we have the vulnerable soft tissues in older patients, medical comorbidities, limited surgical reserve when we decide to go with surgery to fix the pelvic ring. We have also difficulties with compliance with post-operative weight-bearing protocols. And if we decide to conserve, we have the complications of prolonged weight-bearing restrictions. We would like to differentiate between the fragility fractures and the insufficiency fractures. Fragility fracture, the bone fails after low energy trauma. So low energy trauma to the weakened bone will lead to a fracture. It is caused by a mechanical force that would not fracture the normal bone. While insufficiency fractures, the bone fails during normal daily activity without history of trauma. So it is caused by the physiological load, the physiological stress applied to the bone with deficient elastic resistance. These insufficiency fractures are usually diagnosed by clinical suspicion and often delayed in diagnosis. We have a patient presenting with insidious onset of low back pain or pelvic pain, symptoms exacerbated by weight bearing and relieved by rest, with progressive loss of mobility and independence. Then we will suspect this patient to have an insufficiency fracture. And we will do our radiological workup, AP inlet and outlet views. Most of the cases will need CT scan to settle the diagnosis. And we should differentiate the radiological pictures of insufficiency fractures from osteoblastic deposits. When we see these lesions, they are usually sclerotic with trials of healing and callus formation, but still with preserved facial planes, no bony destructions, and there is lack of soft tissue mass. MRI examination is more sensitive to detect occult pelvic insufficiency fractures, whether anterior or posterior, and a bone bruise in the sacral area may be the first MRI sign of insufficiency fracture. This means disruption of the cancellous structure of the sacrum, like we can see here in these MRI pictures, even before we detect these fracture lines in the CT scan. When we talk about the pelvic fragility fractures, we have three important questions to answer. Does injury pattern differ in fragility fractures of the pelvis from that pattern in young age groups? Do we need to have a specific classification? And how can we treat such fractures? And the answer for the injury pattern is yes. We have a different injury pattern in pelvic fragility fractures. We have usually osseous disruption. Osteoligamentous is rare. It is seen only in high energy trauma, but in low energy trauma, in fragility fractures, the disruption is osseous through the pubic ramy anterior or the sacrum, and sometimes the iliac bone posteriorly. So it is bony disruption, both anterior and posterior pelvic ring. Usually the disruption is undisplaced or minimally displaced at the beginning. Do we need a classification for fragility fractures of the pelvic ring? And the answer is yes. As we have different injury pattern, we need also a comprehensive classification of fragility fractures. Thanks to Professor Romans and his group, they described this classification for fragility fractures of the pelvis. They reviewed 245 patients over 65 years of age, and they analyzed the morphological appearance of these fractures, and they could identify 4 fracture patterns. Type 1, isolated anterior pelvic ring lesion. This is the first stage of pelvic fragility fractures, to have isolated anterior pelvic ring lesion. Type 2, we have non-displaced posterior lesion combined with an anterior one, and we don't have displacement. These are usually showing minimal instability. Type 3, we have a posterior unstable lesion. This is the difference between type 2 and type 3. Instability of the posterior lesion, this means we have displacement. Type 4, we have bilateral posterior instability of the posterior ring. So the difference between type 3 and 4, type 3 is unilateral posterior instability. Type 4, we have bilateral posterior instability of the pelvic ring. What about fracture progression? Fracture progression is a real phenomena in fragility fractures of the pelvis. Again, thanks to Professor Romans and his group, after reviewing 148 patients, they could identify progression of fracture in nearly 15% of patients after non-operative treatment. Female patients have high risk of fracture progression than males. What is fracture progression? The fragile bone may fail to heal due to metabolic and or mechanical factors, like the case we presented at the beginning of our lecture. And in this, we will have persistent pelvic pain, progressive deterioration of ambulation, progression of fracture, and deformity of the pelvic ring. This deformity is usually internal rotation and sagittal malrotation of the pelvis. This is fracture progression that will proceed to non-union. What about the treatment of fragility fractures of the pelvis? This depends on the classification type. For type 1, we have only anterior bony disruption. Non-operative treatment is applied, and we address and correct the metabolic error in the patient. Type 2, we fix the posterior fracture percutaneously, percutaneous iliosacral screw fixation, or sacroplasty. What about type 3? Again, if we can achieve closed reduction, we will proceed with percutaneous iliosacral screw fixation, or we may need to do open reduction. In type 4, we may apply again percutaneous transiliac transsacral fixation, and in complex cases, we may need lumbopelvic fixation. So the percutaneous iliosacral screw fixation is a working horse in fixation of the sacral fracture in pelvic fragility types. It is a safe, minimally invasive procedure in such fragile patients. However, if we look to the sacrum in this CT cut, in this CT transverse cut, we can see how empty are the ala of the sacrum. So we expect to have increased failure rate of iliosacral screw. For this reason, we need to improve our internal fixation technique to have longer screws, more screws, combination of fixation techniques, augmentation of screws by bone cement, to apply posterior bridge plate, to use these bridge plates as locked plates, to have lumbo-pelvic fixation, which is invasive in such fragile patients. And lastly, to have sacroplasty as a useful technique in some patients. This is an example of the use of percutaneous transiliac transsacral screw fixation, and the outcome is encouraging. This technique lessens pain and improves ambulation, and still it is a minimal invasive technique. And if we use 2 screws, this will augment the fixation and the stability of the construct. Again, cement augmentation of iliosacral screws may be a solution. It increases the perches of iliosacral screw 3 to 4 folds. In biomechanical studies, this technique has greater pull-out forces. So we inject bone cement around the inside the channel around the iliosacral screw. The posterior bridge plating is another method of fixation. Screws are inserted into the sciatic buttress, so we can have long screws into the dense iliac bone. We can augment the fixation by iliosacral screws as well. An alternative is posterior iliac external fixator. Lumbopelvic fixation and triangular fixation is the method of choice in complex cases with U-shaped fracture and spinopelvic dissociation, but it is an invasive tool in such fragile patients and should be applied only in selected cases. What about sacroplasty? It is the same like vertebroplasty, same philosophy. Image-guided technique, effective choice for rapid pain relief and early mobilization of the patient. What do we expect after fragility fractures of the pelvis? What is the long-term clinical outcome? 20 to 30% of cases showed decreased physical functioning and the quality of life. To summarize the differences in pelvic fragility fractures and fractures in young adults, we have the mechanism of trauma as high energy trauma, in fragility fractures, low energy trauma, pattern of injury in young osteoligamentous, we have disruption of the symphysis pubis disruption, sacroiliac joint disruption, but in fragility fractures, we have osseous disruption, pubic ramy fracture anterior, iliac or sacral fracture posterior. Fracture progression is not known in young adults. Fracture progression is a real phenomena in fragility fractures. Sacral fractures in young adults, transforaminal in many cases. In fragility fractures, we have usually alar fractures. The bone quality is good in young adults, poor in fragility fractures. Insufficiency fractures can be seen in young adults after corticosteroid intake or irradiation. but can be seen spontaneously in older patients. Fixation failure is rare in young adults, can be seen more in fragility fractures. Our take-home message: pelvic fragility fractures are challenging. They have different injury pattern. They need diagnostic workup, especially in insufficiency fractures. The options for operative treatment are iliosacral screw or transiliac transsacral screws in order to have better fixation in such poor bone quality, augmentation of screws by cement or sacroplasty. Failure rates and complications are expected. Fracture progression is a phenomenon. However, we still have opportunities for improved surgical options. Thank you very much for your attention.
Thank you so much, my dear Professor Osama Farouk, for this very interesting presentation. Thank you, sir. Thank you so much, sir.
Thank you.
If we have any questions to Professor Osama. Okay, thank you so much, sir. It has been a great honor for us, sir. Thank you so much.
شكرا جزيلا لحضرتك.
شكرا جزيلا يا استاذنا الغالي.
اتشرفت الحقيقه بوجودي في الجلسه دي اللي فيها عمالقه.
ده شرف لي انا يا فندم، شرف لنا كلنا.
شكرا دكتور اسامه.
شكرا دكتور اسامه. هيتكلم دلوقتي
شكرا.
كل العمالقه الدكتور محمد الشافعي والدكتور محمود الرصاصي وكل الاخوه الزملاء الافاضل اللي في الجلسه. عشان
انا بعتذر على التاخير اللي حاصل يا فندم، معلش العدد كبير قوي فانا اسف يعني.
شكرا جزيلا.
حضرتك عملاق يا دكتور اسامه من غير اي حاجه والله. أنا شاكرين جدا. Good evening to everybody and thanks Prof. Al-Ashhab. Thanks for the audience who staying that late. This topic is actually the dry science is a bit difficult, but we try to make it as easy as possible. I'm going to talk about management of fracture femur, which everybody in audience and speakers are expert in this topic. But we're going to add the evidence-based approach so that we may learn something new. So the objectives of this talk is first is the management of fracture femur, which you already know the basics, some controversial issues and questions that really does not have a clear answer until now. So we're going to tackle this. We see the variation in practice between surgeons. Every surgeon do it differently between different hospitals, different universities, different countries, different background of experience. Okay, and then we're going to look at the definition. We're going to look at just having problem here. I want this part to, sorry for that. Look at the definition of evidence-based medicine, and then look at the application of evidence on fracture neck of femur. Okay. I couldn't advance the slide. Okay, when we have a fracture neck of femur, if it is intracapsular or extracapsular, with intracapsular, you may have option. With extracapsular, we have one option, and these are the basics that everybody will apply. But when we come to questions that doesn't have answer, like for example, if it is intracapsular, would you fix by screws or plate? Would you do a DHS or would you do for a hip replacement? And when you do a hip replacement, whether you do a hemi or a total, when we operate, should be today, tomorrow, or next week? Should we use traction? What are the rules of using antibiotics? Also DVD drugs, drains, blood transfusion. How about the post-operative bed rest? When the patient can walk with a full weight bearing or not? And then when we're going to talk about implants, which is currently a problem in Egypt, about availability. If you don't have, for example, joint replacement, then you may have to use a fixation in a patient where joint replacement is indicated. So availability is a big issue. Economical constraints in different places, hospital and national policies, and then surgeon preferences or his knowledges. And then we're going to talk about new technology, A patient also seeking fancy options from internet, commercial companies and their influence, especially that everything is commercially driven now, drugs, trauma implants, elective implants, and others. So how are we going to answer this question? It all depends on the way you practice medicine. So do you practice medicine based only on your training? Or do you practice it? It has always been said that we are slaves to our training. So, for example, if somebody was trained in UK in a certain era, he is going to use his training in spite of this training being even changed. So we are still slaves to all the training that we have. Some using only their own personal experience or advices from colleagues. Some using only preferences of patients, and some using their knowledge and new textbooks, or um, based on recent literature like case reports and retrospective studies, or maybe guidelines from American and British Society. All these are okay. But in fact, we should combine all of them in addition to the high level of evidence studies like randomized controlled trial and meta-analysis. So when we talk about evidence-based, is actually by looking at high level of evidence studies like randomized trial and like meta-analysis. A definition of evidence-based, a simple one, is the integration of the best research evidence with our clinical practice. So there's a combination of these two. And they are components, as you can see here. We have the patient, we have the doctor, and we have the information. And then we got questions or problems that need to be answered. So the 5 main steps for evidence-based medicine is that first is that you have a clinical question, you have a patient-focused or a problem-oriented, okay? And then you're trying to find the best evidence for that through your literature search. Then you get a lot of information. You need to do a critical appraisal for that, and you evaluate the evidence for quality and for usefulness, and apply this evidence by implementing useful findings in clinical practice. So you implement, and then you see the results. So you evaluate, and then you see the intervention that you did and the effect of that evidence-based process. This is a very serious statement when somebody say that in 21st century, clinicians who cannot critically read a paper or a study is as unprepared one who cannot take blood pressure or examine the cardiovascular system if he is like a junior doctor. As we know, the level of evidence for the studies that's published are 5 levels. So when we ask an expert in the field, so for example, if you ask the top surgeon in fracture neck of femur in the whole world, this is level 5, which is the lowest. And after that is a case study or case report or series, and then retrospective, which is a level 3, and then a prospective cohort study, which is a level 2, and then level 1, which is randomized controlled trial and systematic review or meta-analysis. So this slide is very, very important because this slide, what we're going to apply to every step of the management of fracture neck of femur in the next slides. This is the same pyramids that we showed before, which is a level of evidence, but it's just done in a more complex fashion, okay? So here we have 17 questions that need to be answered. This collection of literature and the level of evidence is not done by me. This is something that has already been published. However, this is not up to date, which means that some of these 17 questions could have an update maybe at the time of giving the talk. There could be a paper that could be published just like yesterday that I didn't look at, or maybe something that's going to be published today. So this evidence should be updated every now and then. So when we look at this, I'm just having a bar here at the top. I can't get rid. Sorry. Give me a second. So the first question is the time of surgery. Here is the answer to the time of surgery. But this level of evidence is level 3. So when you have a level 1, just go and apply it straight away. When you have level 5, you will just put a question mark on it, and you need to verify it by other means. When you have something in the middle, like a level 2 or 3, then you may take it, and also you have to consider other factors that could make you change that. So the timing of surgery here, no randomized trial evidence available up to now. So we don't have like a level of 1. However, it has been known that early surgery is good. If you do the early surgery within the first 12 hours, the results are not good because your patient need to be optimized. So the best results are between 24, 36, maximum 72 hours. And any delayed surgery after that usually has got complications that could be pressure sores, pneumonia, confusion, and others. Question 2, preoperative traction. This is a level 2 evidence to show that there is no evidence to support its routine use. When I went to UK in 1993, traction was not used at that time, but it was nearly routinely used in Egypt. So I think that has been for a very long time. Nobody's using traction for fracture neck of femur because you're going to do the surgery within 12 hours, within 24 hours, then there is no point using traction. Prevention of pressure sore, and this is a level 1, that all patients, they have to have, mattress, specific mattress, and this is available and cheap, and it's not something sophisticated. Oxygen therapy. This is a level 2 evidence to support the use of oxygen, not only preoperatively, but also after surgery. Definitely during a surgery, patient is supported with oxygen, but after surgery, for 48 hours or 72 hours, they should be administering oxygen. Thromboprophylaxis, this is a level 1. They should have thromboprophylaxis. There is an update every day about this. I mean, currently, aspirin is taking a lead, especially in US, and, other forms of anticoagulation is still in use in different places. And this is a level 1 that we should have to use this. How about pressure gradient stockings? Yes, there is a level 1 to support wearing these stockings or الشرابات اللي هي بتاعة الدوالي. تمام. Type of anesthesia, that's again level 1 to support the use of spinal or epidural or regional anesthesia rather than general anesthesia. How about type of analgesia? This is a level 2 evidence to say that adequate analgesia before, immediately, and after surgery should be done, and nerve blocks could be considered, and it is useful in some cases. Prophylactic antibiotics, again, this is a level 1, and this should be done during induction, so it would be like a 1 hour before surgery to give the highest therapeutic dose, and this is level 1. However, the routine use of antibiotics for a prolonged period, here there is a level 1 of evidence to say no need for this. Okay, this is something that probably could be questioned in Egypt, and many might not agree, but this is the level of evidence to say that the dose should be only the first day of surgery. When I practice in UK, they always ask me on the first day of arrival, what antibiotics are you going to use, and are you going to use 1 dose or 1 day? So either 1 dose before induction, some surgeons use this, and many other surgeons may just use only for 1 day, but none will use beyond 1 day of antibiotic therapy. How about the type of surgery for trochanteric fracture, or a DHS or a nail, whatever it is, it's a fixation. This is a level 1. And using joint replacement for this, yes, occasionally I use this, but the level 1 of evidence support fixation for trochanteric fracture rather than replacement. For undisplaced fracture, intracapsular fracture of the neck, here there is a level of 1 to say that you can either use screws or DHS for undisplaced fracture. And for displaced fracture, this is the one where here you have difficult decision whether to use a replacement or to use a fixation. Here it depends on so many factors. However, the fixation has got a higher risk of failure. But if you have a young patient and you have to do the fixation, then in this case, it has to be done. And you can see the level of evidence is marked in front of every answer, that here you have level 1 evidence. Surgical wound drains, this is a level 2 to say that this is not required. I mean, especially for arthroplasty, I personally stopped using drain now for more than, for just about 20 years. Until 2004, when I was in UK, I was using drains for joint replacement HS. When I went to US, there was no drains used for either in US or in Canada when I practiced there. And that's since that time, which is almost now getting into 20 years. Now in UK, no drains are used, especially for joint replacement, whether knees or hips, at all. In Egypt, I know that the practice, many of the surgeons use drains, but here is the level of evidence, as you can see. Post-operative blood transfusion, this is a level 2 evidence to say it is not required in asymptomatic patients, especially with the hemoglobin, if it is above 8. And if the patient is not symptomatic, no need to use blood transfusion. Even this level is starting to get lower. Some using it up to 7, and even in some centers using it up to 6. I know that many of the anesthetists will transfuse patients post-operatively if their hemoglobin is less than 9 or 10, but there is no evidence for this. Surgical swabs, this is a level 2 evidence to suggest the calcium hydrogenate swabs to be used. For urinary catheterization, again, this is a level 2, avoiding indwelling catheters, and try as much as you can to use intermittent catheterization to reduce the risk of infection. Nutritional status, this is something very important and is usually ignored. I actually do this especially for not only for trauma patients, but also for elective patients coming for joint replacement. And this is very, very useful to fight infection and also to improve the rehab. These patients should have nutritional assessment. Some evidence support using oral protein supplement for 6 months after surgery. Nasogastric tube feeding for some patients is needed. And this is level of 2. Mobilization, this is a level 3 evidence to say early assisted ambulation within 48 hours. And rehabilitation, level 2 evidence to suggest coordinated rehab program early in the post-operative period. And this should be assessed, and patient will not be discharged unless they have really been assessed and their home situation to make sure that they are safe. We answered all these 17 questions, and I'm happy to take any questions after this talk, and thank you for listening.
Thank you so much, Professor Mahmoud, Mahmoud Hafez, for this very interesting talk and this evidence-based talk about the fracture of the femoral neck. If we have any questions to Professor Mahmoud. I think we have no questions, sir. And if we got any questions, yes, we. Yeah, someone is asking about hemiarthroplasty or total hip arthroplasty. Someone, his name is not. Yes, Dr. Fahd. Yes.
Just
Fahd.
quickly, it depends on many factors. It depends on many factors. I mean, if you have a patient who's coming with a fractured neck of femur, and you know, activity level is the most important rather than chronological age. So we're looking at the physiological and a functional age rather than the chronological. And if the patient is active, try to do a total joint replacement rather than a bipolar or a hemi. One point I just want to mention that I noticed that some of the trainees, they always think about having a bipolar for the young patient because their acetabulum is normal, so that they don't want to replace the acetabulum. In fact, this is completely wrong. Because if you have a young patient, you have to have total hip replacement, because the worst articulation is when you have a metal against either cartilage or bone. This will be eroded, and then this patient will suffer when they have total joint replacement later on because of the lack of bone stock. So this is my message, is that young patients, total hip replacement, not bipolar.
Thank you, sir. I think we have no more questions. Thank you, sir. Thank you so much, Professor Mahmoud Hafez.
Thank you so much. Thank you.
Stay with us, sir. Thank you so much, sir. Our next speaker will be Professor hatem galal zaki, Asyut University. Professor hatem هو من هو طبعا، ويعني وريبريزنتيف بتاع سيكو، يعني دكتور حاتم بيه يعني قمه وعلم يعني. Professor hatem will speak about multiligamentous knee injuries decision making. Professor hatem, please.
Thank you very much, Professor Mohamed, for the kind invitation and for arranging this great international webinar and the great effort. So I appreciate your invitation with all our professors and colleagues. So the talk today is about the decision-making in multi-ligament knee injuries. And I'll try to give you an idea about how we define it and how we make up our decisions. So these are my disclosures. So the intended learning is we define multi-ligament knee injuries. We tell you about the types and actually the principles of management, how we approach them and when to do what needs to be done. In general, when we say multi-ligament knee injuries, we mean 2 to 4 ligament knee injuries. So less than 2 is not a multi-ligament. We need at least 2 ligaments to define multi-ligament. When we have an actual knee dislocation, that's actually quite rare, fortunately. Less than 0.2% of injuries in general. And we do consider them as a very serious injury with potential life-threatening injury due to the neurovascular injuries that may happen with them. So they are a very serious injury. They should be assessed well and decision taken properly. Amputations does have an instance in these injuries. So if you don't pick up the vascular injury, that can have serious consequences. So the classification, the Schenck classification, he defined KD, which is knee dislocation 1, when you have one of the major injuries, which is ACL or PCL injury. KD2, if you have both the ACL and PCL injured. 3M, which is the 2 central plus the medial ligament injury. 3L, which is the 2 central plus the lateral injury. 4, when you have all the 4 major ligament injuries, and type 5, which is a fracture. Some people differ. I mean, when they say knee dislocation or multi-ligament, it's the same, but it's not actually the same. For the knee to actually dislocate, usually you need your ACL, PCL plus one of the collaterals to be torn. So you cannot rarely have a knee dislocation just with ACL and MCL, for example. So that's why really the knee dislocation can happen with a KD3, 4 or 5, not less. So KD1 and 2 will not be actual knee dislocations, but it will start from KD3 and 4. So the clinical presentation, there's obviously a high energy trauma, but sometimes it's a very subtle injury in obese patients. So don't underestimate that low fall on the ground in obese patients. Deformity will be easily looked at, swelling and ecchymosis from the rupture of the capsule. Dimple sign may happen, which is when you have buttonholing of the medial femoral condyle through the medial capsule. You must check the stability, and the most important is neurovascular examination for any emergencies. We published a long time ago with one of my consultants, the chronic irreducible post-rotator dislocation. So when you look at an X-ray like this, and even if you try to reduce it on the X-ray, you see there's a widened medial joint space that sometimes may signify buttonholing of the medial condyle, and it's an irreducible dislocation. And if you look at the MRI, you can see that the medial collateral ligament is actually inside the knee, and that's why the medial condyle is buttonholed, and you cannot reduce the medial compartment, and this has to be done surgically. There are certain red flags that we must look at. Hyperextension of the knee, usually that means both cruciates are gone and the posterior capsule. Popliteal ecchymosis, that might happen if there's a vascular injury. Of course, we're going to examine the vascular status, examine the peroneal nerve. Sometimes if you have rupture, there's lack of hemarthrosis. So it's not actually swollen. You might think it's not swollen, it's not a problem. But if you actually rupture the capsule, there's no actual knee collection. And don't forget, you might have a very trivial trauma with obese patients that causes a multi-ligament knee injury. It's important to do clinical assessment for the ACL, of course, anterior broad Lachman test, PCL for the SAG sign. We test for medial and lateral in about 30 degrees of flexion, and we test for the posterolateral corner also with the dial test. It's very important to do the proper investigations, X-rays, MRI for all patients. Duplex ultrasound is the minimum to be done. And if the ankle brachial index is less than 0.9, you must do a CT angiography. So these are standard procedure. You must do the first three in all cases of multi-ligament knee injuries to make sure you don't miss a vascular injury. Popliteal injury is up to 30%, sometimes go up to 40 and 50% in some studies. If that's the case, you need a vascular surgeon to come in and repair. At that time, the orthopedic operation will be delayed. You need to do an external fixator, and the vascular surgeons will be working. Common peroneal nerve injury, again, is almost 1/3 of the cases will have that, so you must examine for that. The ankle brachial index is very important. Normally, it's above 0.9. If it's between 1 and 1.4, which you test the blood pressure, systolic blood pressure in the ankle and in the brachial artery. It should be higher. However, if it's less, that means you might have a vascular injury. So if the ankle brachial index is less than 0.5, 0.9, CT angiography must be done. It has high sensitivity and specificity when you're related to that. So don't be afraid to do that. It's very important to check for vascular problems. For common peroneal nerve injuries, sometimes they're incomplete or complete. It has been shown that when you have an incomplete injury, so some muscle weakness, then most of the time these will recover and have a good outcome. In complete cases, only about 40% recover. If that's the case, up to 3 to 6 months, no recovery, then you could go for a tibialis posterior tendon transfer to restore the foot drop. So when do we do an external fixator? Major trauma, open fractures, vascular injury, if you have compartment syndrome, very unstable knees, if you have multiple forward ligament injury, dislocatable, sometimes you need to do an X-fix, polytrauma if you need to do a DCO before you manage the knee, and in very obese knees, when they're very big thighs, the brace doesn't do a good job, then you need to do an external fixator to keep the knee in place till you do your definitive surgery. So the important decision is time of surgery. Are you going to repair or reconstruct? Which grafts are you going to use? Are you going to do it staged or not? And the mobilization and the rehab post-op. Now, surgery is the way to go. Most of the literature supports surgery. No one does non-operative and multi-ligament knee injuries. So the old teaching of doing it in a cast or a splint, and then we don't do that. If you suspect it, you must do your MRI. If it's confirmed, then you must plan for the surgery. Now, when do we do that? It can be done acutely within 3 weeks, staged, in which you do the outer ligaments in the first 3 weeks, and then after another 6 weeks, you do your ACL, PCL, or in chronic cases if they present late, but then you have to reconstruct all and you're looking for more graft. So the advantage of the acute is that you're able to repair some of the ligaments, such as the MCL. So you're reducing the graft needing. For the reconstruct, if you do for the chronic one, then you need to reconstruct everything and you need grafts for everything. So what do we do? For ACL, we do reconstruction. Either you're going to do the surgery open or arthroscopic, depends on the skill available. You can do the PCL, again, open arthroscopic. The posterolateral corner, we're going to do a reconstruction. Of course, that's open. It's the MCL that also has good outcomes if you do a repair in the acute phase within less than 3 weeks. So this is the advantage of doing it acutely. You can repair the MCL and the outcomes are equal to reconstructing. But in the top three, the ACL, PCL, and posterolateral corner, they should be reconstructed, especially posterolateral corner. It has been shown reconstruction gives better outcomes than repair. So where do you get all these grafts? So you can have the hamstring of both knees. You have the quad tendon on the same side. You have peroneus longus on both sides. And this is a very good addition to our scope of grafts, and it's easy access. I encourage everyone doing knee ligaments to learn peroneus longus grafts for their normal ACL. So they have these available for the multi-ligament and, of course, the bone tendon bone. For the MCL, if we're going to do reconstruction, then we use ipsilateral hamstring. We leave the distal hamstring attached, and then we do the pyramid reconstruction with the posterior oblique ligament. For the ACL, we use the peroneus longus or quad. For the PCL, we use the hamstrings And for the posterolateral corner, again, we're using either the peroneus longus or the hamstrings for the other side. I prefer to do the Laprade technique, but I use one graft, which is through the Y technique modification. So this is an example actually of a patient he came with a trial stage procedure. So someone operated on him, did an MCL and a lateral collateral ligament repair. This failed in this patient. He's actually quite a large patient. And he still came, the ACL, PCL were gone, and the MCL, LCL were very lax. So the examination showed grade 3 everything, ACL, PCL, MCL, and the lateral side completely open. Since this was a late procedure, we decided to do reconstruction for all 4 ligaments. So this is after 3 hours of surgery. We did 10 screws, 2 for the PCL and a staple for the graft. We did the MCL POL reconstruction, and we do the pyramid system, also described by Laprade, anatomic-based reconstruction with an extra staple or anchor for the deep MCL. We do the Laprade for the posterolateral corner with 4 screws with a Y graft and 2 screws for the ACL. It's quite a big surgery, so you must plan really the full team for the operation. Now, the literature has shown with different systematic reviews, reconstruction does better than repair. It's better to operate early within 3 weeks, and you get less arthrofibrosis if you do a delayed ACL, but really depends on your system. Are you going to do staged or not? So again, more literature showing this is 60 cases multi-ligament knee injury. Surgical management gives the best results, whether you do them late or chronic, but surgery is the way to go. This study found that doing everything as a single stage procedure is better than doing it on 2 operations. And this is my personal preference. And really the outcome depends on the surgery, the preoperative level, and the rehabilitation after the surgery. Laprade again described over almost 300 cases, anatomic-based reconstructions, early post-op rehab, significantly improved the outcome. And it doesn't matter whether it's ACL, PCL-based, both of them did very good in the results. Then lastly, we come to the rehabilitation. We give them, because it includes PCL and posterolateral corner. We do non-weight bearing for 6 weeks, but with a hinge brace, because we need to start range of motion of the knee as early as possible. So we start partial weight bearing at 6 to 12 weeks, again in the hinge brace. And we start early range of motion up to 60 degrees in the first 1 month, 4 weeks. And then we want to reach 90 degrees in 6 weeks, and MUA roughly to 6 to 8 weeks. And I actually added this as part of the rehabilitation. It's not uncommon that when you do all these ligaments, the knee will become stiff, even if you start early range of motion in the hinge brace and you do a manipulation under anesthesia at 6 weeks. Some surgeons consider that as part of the rehabilitation. You may describe that to your patient. If they're slow in the rehab, do the MUA, they continue their function and they get a much better range of motion. So finally, it is quite a serious injury. It's very important to look at the neurovascular injury. Do your ankle brachial index, common peroneal nerve examination. Depends on the time of surgery. My preference is I do them acute, less than 3 weeks, and I do them as 1 stage, not at 2 stages. I want to save time for the rehabilitation of the patient. It's very important to the grafting. I add and I stress out the peroneus longus graft now. Very good source of grafting. Reconstruction for everything except the MCL. You may do a repair in the early stages. And early post-op range of motion is a key to minimize knee stiffness. Thank you very much.
Thank you so much, sir, for this excellent presentation. Thank you so much, Professor Hatem. We have 3 questions for you, sir, if you allow me.
Of course.
First question from Dr. Yaqub. In knee dislocation, any evidence to do MRI before XFAX?
So I would do an MRI as soon as, of course, it's an emergency procedure. I will not leave the knee dislocated. You have to reduce it. You put it in a brace. You do your MRI so you know what you're dealing with. I don't want to make the patient enter surgery before knowing what I'm dealing with, because sometimes you may need to do things acutely. You have to check the vascular status before. Maybe he has a vascular injury. That means XFIX might need to be done anyway. So I would reduce it, X-rays, MRI, and then properly evaluate vascular, and then I decide what to do.
Yes, sir. Another question from Dr. Gamal Qasim. Can ultrasonography be used as a tool for net diagnosis of knee ligamentous injuries if MRI is not available?
I don't know how clever they will be in the MRI. Of course, you can do for the MCL It depends on the skillful posterolateral corner. ACL and PCL, you cannot really diagnose them with ultrasound that much. I would highly recommend you do an MRI. If you're going to be operating in these very complex knee injuries, my advice is send the patient somewhere to get the MRI, because otherwise you and the patient will be in trouble if you don't have the proper evidence and you know exactly what needs to be done before you go in.
Yes, sir. I'm sorry, sir. We have about 3 or 4 questions also, if you allow me.
Of course.
Another question from Dr. Walid Goma. Sequence of reconstruction if one in staged surgery.
In one stage, so what we do is we go in, we do the tunnels, and then we pass the graft. So we do the central compartment first. We do the tunnels. We pass the graft for the PCL and fix that. And then, so we pass the graft for PCL and ACL, but we fix the PCL as number 1. Then we fix the ACL. Then the knee is stable. Then I usually do the posterolateral corner, and I finish with the MCL, which is the easiest. So I don't want to keep the posterolateral corner till the end because it's actually also a complex procedure. So central compartment, posterolateral corner, then MCL.
Yes, sir. Another question from Dr. Ahmed Majid. Does peroneus longus graft strong as hamstring?
Yes, definitely. There is lots of evidence now in the literature. If you look at all the results, it's as strong as the hamstring tendon. And again, if I have one message for you, the knee surgeons, please go and learn peroneus longus graft. Lots of videos, see it with 1 or 2 surgeons. It is not a difficult graft. Some people are doing it routinely now for primary ACL. So you may do that. Sometimes you're doing your hamstring and it cuts early. You need to have the peroneus longus available right there and then with you.
Yes, sir. Another question from Dr. Ziad Mahmoud. Not sure if this is common with multiligamentous injuries, but do you address patellofemoral joint instability with these as well?
It's not in my experience that there is patellar instability. In some cases I've had, the patellar tendon was actually ruptured in addition to the multiligament. That makes it easy, actually, decision, because then you're doing it open. The patellar tendon is already open. You just open the knee, you do your ACL, PCL, then you fix back the patellar tendon, and then you do your collaterals. But I've not seen actual instability, and I don't think in that setting of a large trauma, you're thinking about the MPFL and how it would get injured in something like this.
Yes, sir. Another question, sir, from Dr. Saad Abu Zeid. If patient with knee dislocation with vascular injury, should I apply X-Fix? And if so, who will interfere first, orthopedic surgeon or vascular surgeon? How to apply X-Fix in order not to hinder vascular repair?
So it will be a cross knee X-Fix. So both of you will enter the operating room. The orthopedic surgeon starts, you reduce the knee, you put 2 Shanz pins in the femur, 2 Shanz pins distally in the tibia in slight flexion position to help the vascular repair. You're not going to put it in full extension, slight flexion position, and then you're going to finish your X-Fix and leave the surgery. Then the vascular surgeon probably will put the patient, will twist the patient, and then we'll be working on the knee. It will be difficult for you to operate after the vascular surgeon. You may disrupt his repair. He needs stability before you operate, before he operates.
Another question, sir, from Dr. Ahmed Hussam. What's the protocol of management of multiligamentous injuries with tibial plateau fracture?
It's what you need to do everything together. Obviously, what I've seen, usually what I've had is having an ACL, for example, and a tibial plateau fracture. So I do everything at the same time. So I fix the plateau, I do the internal fixation, and at the same time, I would repair the ligaments so that the patient will have early rehabilitation. So I've had cases which have done MCL or posterolateral corner with the tibial plateau.
Yes, sir. Another question from Dr. Mohamed Riyad. If staged procedure selected, when to start second operation, sir?
Second operation, usually after 6 weeks. So you'd have to stabilize the collaterals in the hinge brace for them to heal. Once those heals, you're doing early range of motion. Once they heal, you could do at 6 weeks the central tendons, central ACL, PCL.
I'm sorry, sir. We have 2 or 3 questions in the chat box.
Of course.
Okay. Another question from Dr. Fahd Kada. In irreducible dislocation, for example, post-total knee arthroplasty hinge type, you still go for advanced imaging or straightforward to the operating theater and open reduction?
Sorry, he said dislocation after arthroplasty.
After arthroplasty, sir.
I will refer it to Dr. Mahmoud.
Yes.
I don't
I
have
will
any.
take it. I will take. I will definitely take it.
I think we have just one more question to Professor Hatem. Can we use the percutaneous, peroneus longus alone for add?
I don't understand. Maybe he means for ACL. Is that correct?
Yeah, for ACL. I'm sorry.
For ACL, yes, definitely. Lots of papers are coming out now comparing hamstring and peroneus longus grafts, and they're showing equal results and no affection of the on the ankle. So this is a nice graft. I used to take all the time quad tendon in addition to the hamstrings. I strongly advise you try the peroneus. You'll be very happy. It's a very nice addition. We're using it in shoulder now as a free graft. We're using it in the knee. So yes, you can use it for primary ACL for sure, and there's evidence to support that.
Yes. Thank you so much, Professor Hatem, for this excellent presentation. Thank you so much, sir.
Thank you, sir.
Our next speaker will be Professor Mohamed Elshafie, my big brother, Professor Mohamed Elshafie, Professor of Orthopedic Surgery, Minya University. Professor Mohamed Elshafie will speak about how to fix medial tibial plateau fractures. Professor Elshafie, please.
Bismillah ar-Rahman ar-Rahim. Welcome to all. First, greetings and congrats to Professor Al-Ashhab for such an enormous effort and international webinar. Thanks to the speakers, international speakers, and thanks to EVA company for sharing. I would like to talk about a medial tibial plateau or medial tibial condyle fracture, which is used to confuse me in the past. Why it is different, why it is not very clear, it is not behaving constantly. Is it a pure fracture or a fracture dislocation? There is a wide range of soft tissue injuries associated with it. But I figured out that it is either a coronal or sagittal fracture. Either should be regarded as subluxation or dislocation until proved otherwise. The coronal fracture, as we see, it is caused by compression of the medial femoral condyle in hyperflexion, and the fragment is always large and not comminuted fragments. This coronal fracture occurs only in the medial plateau, probably because of the buttressing of the superior tibial joint to the lateral one. It may involve up to half or more of the medial tibial articular surface, and it displays distally with the medial femoral condyle, subluxing with it infromedially. And the rest of the plateau subluxes anterolateral with the ACL injury is common. And we see that there may be a translation of the lateral tibial plateau. This is a lateral translation. We can see the ACL avulsion imminence. We can see the capsular sign or sign of ACL injury. In this X-ray, we can only or hardly see the fracture, but we can see the double contour of the posteriorly depressed posterior half of the medial condyle. Because it occurs in hyperflexion, it greatly affects the mechanics of the knee as rolling and occurs in flexion. So it must be stabilized. Also, because it occurs in hyperflexion, the neurovascular injury is rare. And when we extend the knee, it is usually stable in mediolateral stressing. This case of a 45-year-old lady presented with a varus, unable to weight bearing 3 months after fixation of medial tibial condyle fracture. The X-ray shows the varus. The articular surface is probably reduced in this X-ray, but the plate is anteromedial. The oblique view shows the posterior condyle, posterior part of the medial condyle is distally displaced. And the coronal cut of CT shows that the coronal fragment is completely missed. So it's a fixed plate and screws to one part of the bone, missing the other fragments. And this is the CT. And intraoperatively, after removal of the plate, the fragment is displaced inframedially, and just elevating this and putting an anti-glide plate did the job, maintain the reduction, and the fracture healed. Coming to the sagittal fracture, which is the other side of the lateral tibial plateau described by Schatzker and colleagues. Schatzker could describe this as a type 4 fracture, fracture of the medial tibial condyle, but in a rather confusing way. They subdivided this into A or B, whether it is comminuted or not, whether it is porotic or not, and it may be a part of dislocation, and it may fracture the eminence. However, the key is the fracture exit in relation to the eminence. This is the type 2 fracture in the Moore and Hall classification of the knee fracture dislocation. This is type 2, which is they called entire condyle fracture. This is distinguished from Schatzker type 4 fracture by the fracture is passing under the eminence and go to the other condyle. And it may involve the medial or lateral plateau. On the medial condyle, the both cruciates and the deep MCL remain intact. So the medial condyle stay, and rather the lateral one with the tibia is the one who subluxes laterally. The lateral collateral ligament is involved in half of dislocations, or fracture of the proximal fibula may occur. And with such a displacement, both peroneal nerve and vascular injury rates are significant. This paper looked at the a new classification with a prediction of associated soft tissues, and they classified the medial condyle fracture into type A, where the fracture is medial to the intercondylar eminence, B is within the eminence, and C is rather passing the lateral to the eminence, which is the entire condyle type described by Moore. Type C, which is lateral to the eminence. And the neurological and vascular injuries seen were only in type C fractures. The more lateral the fracture, the more the compartmental and vascular injury, and the less ACL and meniscal injuries. So the sagittal medial tibial plateau fracture is a high energy mechanism injury. It is unstable, represent a variant of knee dislocation. It is caused by shearing or transverse force, displacing the remaining plateau with the tibia laterally. So this presentation, schematic presentation, is probably wrong. The medial condyle does not move, rather than what shows in the CT real, that the medial condyle is stay in relation to the femur, and the lateral one with the tibia is the one who moves laterally. And this is an X-ray one case. The medial tibial condyle is in normal relation to the medial femoral condyle with an intact cruciates and coronary MCL. The lateral tibial plateau moves or translates laterally. And this well shown on the CT, that the fracture passes under the eminence to the middle of the lateral tibial plateau. I go from the lateral side, taking care of any incarcerated fragment or meniscal injury on the lateral side, doing the reduction and fixing by lock the plate. It is actually surprisingly good result with this injury, probably because there is the cruciates are intact, minimal ligaments injury, and if there is no vascular injury, this result is at 10 weeks full range of motion of the knee. Another case with much more grave displacement, The lateral tibial plateau with the tibia displaces and locked lateral to the lateral femoral condyle. And this is well shown in the MRI. Again, fixation on the lateral side by a locked plate with excellent result at 10 weeks. Full range of motion and good power. Another case with an even more dislocation. The medial condyle remains its relation to the medial femoral condyle. Even in the vascular compromise after reduction with the hafez fracture fixed, it is a good range. So the medial tibial condyle fracture either is coronal or sagittal, and it must be regarded as dislocation or subluxation until proved otherwise. Expect meniscal cruciate neurovascular injury as the fracture exits more laterally. The MCL is usually intact. The lateral collateral ligament may be injured with severe displacement. The coronal fracture fragment displays distally, so it must be fixed by an anti-glide plate with compression. However, the sagittal fracture of the medial tibial condyle displays transversely with widening or translation, and it must be compressed by a buttress plate. Thank you very much.
Thank you so much, Professor Mohamed elshafie, for this very interesting presentation. I think we have a question for you, sir. If we fix the plateau, does the ACL will be lax or it will be fixed tight and not affected?
As we said, if the exit of the fracture is lateral to the eminence, then we expect that the both cruciates are intact. But if it goes through the eminence of the ACL, may be avulsed, and it is avulsed usually with the coronal fracture of the posterior medial condyle.
Yes, sir. If any other questions to Professor Mohamed? I think we will have a lot of questions because it's a very important subject, Dr. Mohamed.
Thank you very much. Greetings, Professor Ash.
Thank you so much, sir. I think we have no more questions. Yes, we have one question. Do you fix at the same time with the plateau? No, do you fix? No, I'm sorry. Do you fix ACL at the same go with the plateau?
Yes, if it is a bony injury, I fix at the same time. If it is a soft tissue injury, is interstitial injury, then I reconstruct late.
Yes, sir. Okay, I think we have no more questions. Dr. Mohamed, thank you so much, sir.
Thank you.
Thank you so much, sir. Thank you so much, sir. Our next speaker will be Prof.molhem Mahmoud, Professor of Orthopedic Surgery, Cairo University. Professor Molhem will speak about combined pelvic and acetabular fracture in adolescent. Professor Molhem, please, sir.
Good evening, dear professors and colleagues. Thank you, Professor Mohamed, for this kind invitation and for your great effort. You hear me?
Yes, sir. We can hear you, sir. We can hear you,
okay.
Sir.
And the screen is shared?
Yes, sir.
Fracture in combined fracture pelvis and acetabular in adolescence. This is a 16-year female patient hit by a heavy truck. From the emergency plain X-ray film, we can find she had fracture pelvis, right superior pubic ramus, inferior pubic ramus, left fracture acetabular. She had associated injuries, left Montagia fracture dislocation, rim collection, retroperitoneal hematoma. She was admitted to ICU. And now the question, what is the ideal orthopedic management for her fracture pelvis? Either conservative or operative. The conservative supporter will say she is a female, 16-year young female, and the fracture pattern is none or minimally displaced, so we should treat this fracture conservatively. On the operative side, we should answer this question. Is this indicated for operative intervention? What is the method of fixation? What is the sequence of intervention? The objective of our lecture: young age effect on decision-making of management of pelvic trauma, patterns of combination, importance of searching about the hidden pathology, and the ideal management. Age effect. Young children pelvic fractures and injuries are peculiar. In this talk, we are not talking about children injury of pelvis, but adolescents. Adolescence means age between 13 and 19. Any patient above 13 years of old, their pelvic fractures characteristic and indication of operative treatment are equivalent to those in adult. And this is the most important statement in my talk. The aim of operative intervention: emergency measures for damage control associated pelvic organ injuries, stabilization of fractures and restoration of the anatomy, and avoid later complications as limb length discrepancy, osteoarthritis, and so on. The spectrum of injury, the combined pelvic and acetabular fracture, range from the left picture, which we hardly can see the fracture, to the right one, which measure displacement and fracture and dislocation. So it is not one type. The mechanism of injury in this combined injury is not clear as single. Usually there is a lateral injury vector, an external rotation force, and usually combined mechanism of injury. On the pelvic side, usually the injury type are anteroposterior compression and lateral compression. And on the acetabular side, usually transverse, T-shaped, and associated both columns. But any type can occur. This is the statistically type according to statistic. The associated injuries: there is a high injury severity score, need for blood transfusion, many other system and organ injuries. So we should follow the general rules of management of polytrauma patients. First, we should define the fracture and the injury through precise, systematic, and detailed imaging. Easy to focus on the acetabular fracture. Please don't overlook the subtle injuries. The scenario is that usually the acetabular fracture is very clear. So every patient has a acetabular fracture, you should search in detail the rest of the pelvic ring to not miss any combination injury, because these combination injuries is common and more common than we think. The potential combinations are acetabular fracture plus anterior pelvic ring injuries, posterior pelvic ring injuries, and combination of both anterior and posterior pelvic ring injuries. We turn back to our case. This is the anteroposterior film we have seen. Now, after making an oblique obturator view, we found this. So this is fracture acetabulum transverse type with a posterior wall large fragment and maybe have been dislocated and reduced hip. Doing outlet view, looking at the sacroiliac joint in a more detailed, precise way, you can find that there is a sacroiliac injury. the sacroiliac is widened and there is a fracture at the ala. More precise, looking at the elid view, you can find that the sacroiliac joint is not in its place and compare it to the sound side on the right side. So definitely there is a sacroiliac injury. Going more detailed by studying the TT cuts, the axial cuts at the acetabular level, you can find the posterior wall and the fracture acetabular pattern. With reconstruction, 2-dimension, you can see more detail of the fracture pattern. At the sacroiliac joint, now we can notice that the sacroiliac joint is completely disrupted. It is not a mild injury. With reconstruction, 2D view, you can find this is a fracture dislocation at the sacroiliac joint. So after studying in detail this imaging, it is not a simple non-displaced fracture, but this case is a combined fracture acetabulum, transverse posterior wall, plus fracture pelvis, type C completely unstable, posterior ring fracture dislocation at sacroiliac joint, and anterior pelvic injury. So what is the treatment strategy? Consider each injury separately. You should study each injury separately and then plan operative approach. Is it ideal for a single approach? If a possible, or it is a possible for stage and sequential approach. In your plan, please start by making a stable platform. You should build a platform or a base on which you build the rest of your fixation. And this platform should be connected to the axial skeleton. So we are talking about the sacroiliac joint. Concern anatomical reduction, stable every injured point. No mobile point is allowed. In the present case, on the pelvic side, we performed posterior ring percutaneous iliosacral screw fixation, anterior ring percutaneous retrograde anterior column or superior pubic ramus screw, and on the acetabular side, we performed open reduction internal fixation with double plating for the posterior wall and the transverse element. This is the post-operative X-ray, inlet and outlet view showing that fracture pelvis is anatomically reduced posteriorly and anteriorly, and oblique views for the acetabular reconstruction showing anatomical reduction of the transverse fracture acetabulum and the posterior wall. To conclude, adolescent pelvic injury is equivalent to adult pelvic injury. There is a wide range of the spectrum of this combination. Please achieve precise detailed image studying, individualized treatment plan. Consider starting rigid axial posterior platform. Strive for anatomic reduction and rigid fixation. Thank you.
Thank you so much, Professor Molhem, for this very interesting case presentation. حالة رائعة يا فندم والله.
العفو. شكرا يا دكتور محمد.
Thank you so much, sir. If we have any questions to Professor Molhem. I think we have no question, sir. Thank you so much, sir. Oh, yes, we have one question. Dr. Yaqub is asking about sequential fixation.
Yes. As I recommend, you should start by fixing the pelvic ring to the axial skeleton. The problem in combined injuries to the acetabular and pelvic that the acetabular site in the space or location will be changed. So you have to make an stable platform posteriorly to the axial skeleton. Upon this platform, you can build your other fractured part. So we started by fixation the pelvic ring by iliosacral screw and the anterior ring by retrograde screw. Then the patient put on prone position for posterior fixation of the acetabular wall and transverse fracture.
Thank you so much, sir. I think we have no more questions. Thank you so much, Professor Molhem.
Thank you. You're welcome, Dr. Mohamed.
Thank you so much, sir. Our next speaker will be Professor Mohamed Fadel, our dear professor, Professor Mohamed Fadel. Professor Fadel will speak about crushed lower leg bone and soft tissue, a case for discussion. Dr. Fadel, you are with us, sir? Dr. Mohamed, you are muted, sir. Dr. Fadel, you are muted, sir.
Is it right now?
Yes, sir. Yes, sir. Okay.
Thank you. I'm sorry.
Thank you so much.
Good morning for this early marathon day, a new day. We bypassed the other day. Thank you, Professor Mohamed Al-Ashab, for this.
Thank you so much. And sorry for being late, sir. Thank you so much, sir.
No, for these fruitful days, it's very nice and fruitful hours. And you give us a chance to meet experience from the different friends from all over the world. I would like to appreciate your trials and also your invitation. Thank you so much. And also for our participants from all over the world and our friends who share us now from either from Egypt or from different countries all over the world. I am live with you, but I couldn't see that I am in the photo, but I didn't like to play with the camera. May I disturb something? But I am live with you. It is not recorded. I am Mohamed Fadel from Almenia University, 240 kilometers south to Cairo, lying on the River Nile, and belongs to many associations all over the world, but stay that the Egyptian Medical Association is the most beloved one for me. And I'd like to kindly remind you to see you in November with the Egyptian Medical Association and CICUT, which will be also another international live in-person conference. Nothing to be disclosed from this case presentation. When we talk about crush injury of the lower leg, we find that two topics erupted actually in front of us, the bone defect and the soft tissue defect. 2 points will be appear. Many conventional methods are used for bone defect or soft tissue defects and also for combined bone and soft tissue defect. The needs for microvascular consultation is a major obstacle, either to reconstruct the bone defect alone or concomitant bone and soft tissue defect. Another 2 points is that the specific method of skeletal reconstruction of those are a topic of controversy, and the problem increases so much if there is massive bone loss, soft tissue scar, vascular compromise, and short tibial ligaments. Returning to our case, it is a case of multiple trauma patients, open fracture, grade 3B, crush injury, actually not open simple. It is There is a skin loss, crushed muscles, exposed tendons. Moreover, there is a bone shatter, the comminution with deficient parts, and often disturbed joint and tendons exposed, as we see here. At least just the medial and lateral malleolus is in place, and the other is disturbed, the lower third at all. So assessment as usual, ATLS, polytrauma patient should be managed as it is, a serious one. Mangle extremity score to check if it is amenable for salvage or not. And damage control surgery would be assessed. The assessment to not include only the patient, should be include the surgeons, the hospital, the capability of the hospital to deal with such cases, and the post-operative follow-up. The outcome of this is that we have a bone defect and soft tissue reconstruction. Muscular technique, bone transport, vascularized fibroblast is used and conventionally famous that it is a very good solution for bone defect reconstruction. On the other hand, also primary versus secondary, skin grafting, flaps, and femur-fascia flaps successful in many instances to soft tissue reconstruction. So we dealt with it as we think with each other that need aggressive debridement, no wound closure to give the chance for our friends to ask them. So we apply unilateral frame and gives a chance for the plastic surgery. We suggested that he would do the best. We couldn't do this if we have even to stay 1 or 2 days to wait him. So the consultation of plastic opinion is nothing to be added if no working as a team, and it is the case in many instances. So it is a time lag for soft tissue reconstruction, and it is a more problem if we find that we will do the bone first, or the soft tissue defect, or the soft tissue defect, and then the bone, or the combined one soft tissue in one session, which is so difficult. And all agree that all these capabilities should be followed or associated with stability by whatever external fixator, ring fixator, or hybrid or internal fixation. What the plastic surgery chooses to do simple posterior skin release and skin grafting. A long story that resulted in soft tissue failure, and we still have open wound as it is for the crushing, and the tendon is exposed, and the return again for our circle, we call it return option requirement. In these cases, we look for the Elizarov assisted technique as the only solution in our hands, and we are obliged to work as an orthopedic surgeon and a plastic surgeon in the same time. So the operative procedures as used, debridement, sequestrum, if there antibiotic, and application of Elizarov, and looking for using Elizarov assisted technique and using the versatility of the external fixator in these instances, and planning first for the soft tissue reconstruction. We apply a diagram and found that it is 4 centimeter for cubic centimeter and another 2 centimeter on the other hands. So we plan for doing this. Here we can explain that the technique is to do underneath this a wire, then 3 hooked wire attached each one to a slotted threaded rod. This threaded rod and attached to a plate. This plate mounted to the foot and tibia plate. It is looks here well more. How it works, the skin follow this traction kit to cover this area, which is here in the diagram is clear. Another one kit is applied to the other direction to track this to cover these tendons and the bone in this area. Looking for the X-ray to find that the bone is distracted anteriorly and displaced anteriorly, and also in the EP view it is distracted more laterally, and the skin kit is working well. So we will find that later on that also the bone is not working well yet. So we do distraction between the distal part, the distal construct, to have a room for moving by these olive wires, to have the bone to be in between these both ends, between the foot and ankle and between the distal part of the tibia. This is the kit of the skin, how it works, and then after removal of the kit and improving the skin, and then after removal of this huge skin traction kit, we have now the patient walking well, and follow-up proved that there is a very nice and aligned until this, it was this beforehand, and now it although fused, but it works well in alignment and no deformity, and we have a very good skin coverage and everything is well. So either we are working well with our friends in the plastic surgery, but in some instances we are obliged to do both SAM. These techniques have been adopted since 20 years ago. This is a paper had been published by me and Professor Jamal Hosni, and this is presented in Kurgan Elizarov Institute in 2007, around also 20 years. So discussion, we can say why we use this complicated thing. Use it because it is so difficult to use microvascular, so difficult, and you need time to use bone transfer, and muscular technique need more bone, which is in many instances, this is the microvascular, how it needs skill, which is not usually found in our cases. And this is how much bone needed in both iliac wings, which had been taken to reconstruct for this infected non-union for a long time. We need more bone, and also bone transport need more time. So the problem more is for skin coverage to climb this step ladder of the skin climb, or to do this problem of microvascular skills that have been needed. So we can say that looking for as a message or a conclusion, in the case of return option requirements for these cases of plastic surgery and bone and soft tissue defect concomitantly, we prefer to use the Elizarov-assisted technique to solve the problem of both bone and soft tissue defect in one session and by the hands of the orthopedic surgeon on. Thank you.
Thank you so much, my dear Professor, Professor Mohamed Fadel, for this excellent case presentation. It's a disastrous case, sir.
Thank you so much, and I hope that I stick to the time, because I know that it is too late for all of you.
No, thank you so much, sir. We have a question to you, sir, from Dr. Fahd. How you decide the length of distraction, and any difference between Elizarov and TSF in such cases?
Yes. Although actually it is a very good and complicated question, didn't evolve except from a colleague who is working in the field. I think that the problem of measuring the distance, as you see, it is crumpled from up and down. So you do distraction and follow it either by pressure by your thumb to feel the steps, because the tibia is a unique because it is subcutaneously. This is one, but it is not the only to be used. You should do distraction between the foot piece and the distal part of the tibia, distraction more, because you will do after distraction, you will do dragging or pushing the olive wires to rearrange and reposition this scattered and shattered bone from the anterior displacement of the foot. All this construct should be distracted posteriorly, not only posteriorly, but also distracted medially. It is a very complicated one. Actually, though Taylor special frame is unique for doing difficult and so severe, complicated cases, but actually in my hands, as I worked early in Taylor special frame since 20 years ago, but actually by using Elizarov and the manual work of Elizarov, if it is done carefully, the marvelous effect of it in such cases is much better than that of the Taylor special frame, which needs more times, many times, to go through the system and to go through the hardware or the program of the Taylor special frame to rearrange and put numbers and put some angles and to get out and to have output, this output to be followed, or it is a long story in my opinion. I think that maybe those friends who are acquainted and working all daily with the telespatial frame may say against this, but my feeling is that it works well in these conditions, much better than that of telespatial.
Thank you so much, sir. I think we have no more questions. Dr. Fadel, thank you so much, sir, for being with us in this time. Thank you so much, sir.
Oh, you are welcome, and go ahead. It's very nice and fruitful for us all.
I think we have just one more question. Can that applied by external fixator?
Yes, it is a very good question. This is to support our idea that it is not possible to be applied by external fixator, except if a system, a specialized system, had been devised by the orthopedic surgeon to do it. It is not away from our artistic and our, you can say, designing for something to help this. If I would like to do it, I can do it, but it is so problematic. The idea of Elizarov is to apply this to correct angulation, to correct rotation, to correct the displacement, and in all these instances, to correct the soft tissue defect. And moreover, is to give the chance for the patient to walk from the first day of his operation, which is the most unique effect of Elizarov. So it is, in my opinion, it is so difficult and they need a special device. And I didn't know that there is a special device that helps for soft tissue expansion by using monolateral fixator. Otherwise, you can use monolateral fixator assisted with soft tissue expansion, that is the conventional one that had been used by our friends in plastic surgery, or using some assisted things of negative wound pressure or VAC as a famous name, to do some wound closure or reconstruction. But the problem of it is that it needs a bed, a good bed to work on. And in this case, I think it is no bed to work on.
Thank you so much, sir. Thank you so much. Our next speaker will be, thank you, sir, will be Professor, my dear brother, Professor Mahmoud Elrosasy, Professor of Orthopedic Surgery, Tanta University, and one of the administrative board of the Egyptian Orthopedic Association. Professor Elrosasy will speak about post-traumatic complex ankle deformity with infection. Professor Mahmoud, please. Dr. Fadel, would you please stop sharing your screen, please, sir? Thank you, sir. Professor Mahmoud.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته. عذرا على التأخير يا فندم، معلش ظهرت حضرتك معانا يا دكتور محمود.
لا أبدا، تحت أمرك دكتور.
ربنا يخليك يا فندم.
Thank you to Ashab for this kind invitation and enormous work and tremendous symposium today. Good morning, everybody.
Morning, sir.
I will present an interesting case of severe post-traumatic ankle deformity in a 14-year-old child. This child presented to us at the age of 14 years. He had a history of run-over injury on his left ankle joint at the age when he was 7 years old, with extensive bone and soft tissue loss on the lateral aspect of the ankle, managed at that time by initial management, serial debridement and split thickness skin graft. Due to lack of or loss of the lateral support by the lateral malleolus, there was lateral talar subluxation and the drift of the foot into varus deformity. His treating surgeon, to avoid the infection and bad soft tissue condition at the ankle joint, he did a supramalleolar valgus osteotomy. So he created an opposite deformity to correct the varus deformity of the foot. And as we know, two opposite angulations will equal one translation. And the end result is that he presented at the age of 14 years with this severe deformity, where the joint orientation line of the ankle joint was always perpendicular to the joint orientation line of the knee joint, and the foot was placed on the lateral aspect of the leg. And this is the way he was walking. The foot was non-showable. He cannot wear shoes, and markedly translated and angulated with a severe deformity at the distal tip. And to make things worse, we can see here the bad soft tissue condition and the unhealthy skin graft on the lateral aspect of the ankle, with a sinus penetrating into the ankle joint, draining with active infection, extending into the ankle joint. In such cases, we usually put a problem list to be able to put a treatment plan. So if we summarize the problem list for this case, there is severe deformity, ankle joint subluxation, and the ankle is almost disorganized due to long-standing subluxation and the active infection, the presence of deep infection, and the bad soft tissue condition due to unhealthy skin graft on the lateral aspect of the ankle. Deformity analysis and operative planning. We usually do these lines intraoperatively under imaging our surgery. We can see here the joint orientation line of the knee and the joint orientation line of the ankle perpendicular to it, distal. And there is a cora at the distal tibia with the angulation anterior medially about 90 degrees. Traditionally, in such cases, we do osteotomy at the distal, at the cora, apply elrosasy for gradual deformity correction for such a large magnitude of the deformity. However, destruction in such a case, due to unhealthy soft tissue on the lateral aspect, such unhealthy tissue can never withstand destruction for a large magnitude of the deformity correction and the presence of active infection. We usually say that soft tissue loves bone shortening. Whenever you have a bad or unhealthy soft tissue, it's better to go for bone resection to allow safer correction of the deformity without any tension on the soft tissue. So we did resection of the distal tibia, aiming at tibio-talar fusion. As we mentioned before, the ankle joint was disorganized and non-salvageable. So the aim was tibio-talar fusion. So we resected at the level of the cora. We did acute correction of the deformity and the modest shortening, leaving a gap. This transcalcanean wire will maintain the alignment of the foot under the tibia and will guide the transport of the tibial segment to achieve tibio-talar fusion. We did a proximal tibial osteotomy for re-lengthening. For first, bone transport, what's called internal lengthening, and then the lengthening of the whole leg, which is the external lengthening. This is during treatment. Very important that the incision was placed on the healthy convex side, and we do the no skin elevation or subcutaneous dissection. The incision will go through the skin subcutaneous tissue and the periosteum as one flap to maintain vascularity. And despite all these precautions, we can see here superficial skin necrosis of the unhealthy skin on the lateral aspect. However, during the destruction proximally of the osteotomy and at the time of achievement of the tibio-talar docking here distally, we can see here epithelialization and the healing of the necrotic skin and the eradication of the infection. This clarifies or explains the effect of destruction histogenesis on the distal, improving the distal perfusion of the leg and the healing of the soft tissue. In cases of ankle fusion, you have no reference distally to measure the tibial length, so we rely on the clinical measurement of leg length in this way. The patient is sitting on a wheel in a chair with the knees flexed at 90 degrees, and we apply a water scale or ruler on the knees both knees to make sure that both knees at the same level, so automatically the both legs are of the same length. Usually in doing ankle fusion for adults, we intentionally leave the fused side shorter, about 1.5 to 2 centimeters, to allow for rocker bottom shoes wearing. But for this child, he's only 14 years old and is expected to grow more until the age of 16 or skeletal maturity. So we intentionally equalized both leg length, when he is skeletally mature, he will have a residual leg length discrepancy of 1.5 to 2 centimeters, allowing them to use rocker bottom shoes. This is at the end of treatment. Before frame removal, we can see here the regenerate more than about 11 centimeter regenerate of internal and external lengthening. This is about more than 40% of the total length of the initial length of the tibia. And the tibial, very nice tibial fusion. No skin graft or bone graft was used in such case. After removal of the fixator, automatically we have to apply full cast, to avoid regenerate fracture or the deformity, and allow the patient weight bearing for 1.5 months. We can see here very nice consolidation of the regenerate and the fusion side, the healing of the skin, unhealthy skin, and the complete eradication of infection, and marked improvement of the soft tissue condition of the lateral aspect of the ankle joint. And this is the gait of the patient before treatment and the shape of his foot. And after treatment, we can see here the foot is well aligned under the tibia, the gait with equalization of leg length. However, due to the fused ankle joint, he cannot, he is walking heel to heel gait. This is improved by wearing a rocker bottom shoes, as we see here. To compensate for the fused ankle, we can see here the rocker bottom shoes improved his gait too much. Okay. And thank you.
Thank you so much, Professor Mahmoud Rosasi, for this very nice case presentation. Thank you so much, sir.
Thank you, Dr. Asha.
If we have any questions to Professor Mahmoud. It's a very interesting case, sir.
Thank you. Thank you.
Yes, we have one question. How did you deal with deep space?
Yes, we did some acute shortening, the modest acute shortening, and the left space, we did the bone transport and doing the compression destruction. The compression by itself will gradually obliterate the dead space. And as we mentioned before, when we do bone resection for deep infection, you actually do your debridement through a transition zone, not completely healthy tissue. So there is residually infected transudate. Doing gradual compression will squeeze out this infected transudate and gradually obliterate the space. And this is the beauty of the destruction compression technique.
Yes, sir. Another question: for how long is applied?
This case took about, due to his young age, the bone formation was very beautiful, and it took us about less than 6 months to complete his treatment.
Yes. Another question: did you do graft at the docking site?
No, at all. No skin or bone graft, healed spontaneously.
Another question from Dr. Muhammad Osman: can we use fibular transport by Elizarov in this case?
Fibular transport should be reserved for extensive bone loss, tibial bone loss, usually in excess of 10 centimeters at least. But for such cases, it's better to do tibial bone transport.
Okay. Thank you so much, sir. We have no more questions. Thank you so much, Professor Mahmoud. Now we will move to the next speaker. The next speaker will be my dear brother, Dr. Mohamed Laklouk, Professor of Orthopedic Surgery, Minya University. Professor Mohamed will speak about rule of external fixator in tibial plafound fracture. Professor Laklouk, please.
Bismillah ar-Rahman ar-Rahim. Our talk today about rule of external fixation in balloon fracture. First, I would thank my great brother, Dr. Mohamed Al-Ashab, for this great international trauma webinar. And many thanks for our lovely association, Egyptian Orthopedic Association, and here Eva Pharmacy for this sponsoring of this nice meeting. Balloon is a French word for a pastel. We can see the tailors like this pastel. Also, plafound meaning a decorated ceiling. A tibial plafound fracture, also known as a balloon fracture, is a fracture of the distal end of the tibia. Some state that it is about 5 centimeters from the ankle joint. 3 important anatomical structures related to the balloon fractures are the articular facet of the tibio-talar joint, metaphysis of the tibial shaft, and the fibula. Most commonly associated with intra-articular extension, like these X-rays, comminutions, and significant soft tissue injury. So the 3 main structures for a balloon or plafound fracture: significant soft tissue injury, comminution, and intra-articular extension. History of balloon fracture. It is first stated in 1911 by Etienne Destot, and Gerson in 1959 he took that there is imposition. Leach and Sick states that fibular fixation alone is enough for stability of tibial plafound, but Rudy and Algeber in 1969 talk about details of injury of the balloon fracture, and in 1979 talk about the result of open reduction internal fixation of the tibial plafound fractures. The statistics of the balloon fracture: about 1% of all fracture, 10% of the tibial fracture. It represents about 30% of open fractures, and 10% of these balloon fracture eventually go in for arthrodesis of the ankle joint. First, we must differentiate between the fracture of the ankle and balloon fracture. Ankle fracture is typically associated with lower energy mechanism, such as twisting injury or descending from the stairs or sport injuries, and they occur by either pronation or supination injury, which lead to push-off injury or ball-off injury for medial or lateral malleolus, sometimes with rotation and ligamentous injury or posterior malleolar injury. But balloon fracture are intra-articular fracture of the distal end of the tibia that involve a significant portion of the weight-bearing articular surface. Occur with high energy to the ankle may be caused by either motor vehicle accident, fall from height, or severe sport injuries. True bending, the mechanism of injury for balloon fracture either occur with true bending, which is a rare injury and usually occur in porotic bone. Torsion force leads to mainly ligamentous injury, but axial compression, which is the most common cause of injury, lead to more comminution, more soft tissue injury, and more articular damage. Pure compression is rare. It's usually associated with either inversion or eversion. Balloon fracture results from an axial load with disruption of the weight-bearing articular surface. The articular component will involve either weight-bearing surface, medial malleolus, lateral malleolus, or posterior malleolus. The degree of comminution of the articular surface and the damage to the articular cartilage and the joint surface incongruity lead to worse outcome of these injuries. Foot position decide fracture pattern. If the force is applied with the foot in either plantar flexion, like this injury, lead to fractures, result in posterior malleolar injury. Like this mechanism of injury lead to fracture of the posterior malleolar injury. With continuation of this injury, and this is the X-ray of the posterior malleolar injury. If another mechanism of trauma, like sliding in the wet floor, also lead to posterior malleolar injury because there's a vertical compression force with plantar flexion. If the force is applied with the foot is dorsiflexed, like fall from a height with dorsiflexed foot, this leads to vertical compression force and fracture of anterior malleolar injury. Classification of the pelvic fracture. The purpose of the classification is to aid the surgeon in selecting a treatment methods, provide prognostic value. AO classification is the most famous classification. Number 4 means fracture of the tibia or fibula. Number 3 means fracture at the distal end of the tibia, and subdivided into A for C, complete articular, which is more subdivided into 3 subgroup, either simple or wedge or multifragment, split or split depressed or depressed, or simple articular, multifragmental metaphyseal, or multifragmentary epiphyseal and metaphyseal. Rudy and Elgordic classification, there is 3 subtypes, either non-displaced interarticular fracture, displaced without comminution, and displaced with comminution. 3-column classification was based in the CT radiology. This divides the distal end of the tibia into anterior and posterior column by the intermalleolar line, lateral column by the fibula, and the medial column for medial malleolus. Because we deal with external fixation, we must know a lot for soft tissue injury so we must know the AO soft tissue classification is either closed skin lesion or open skin lesion. Closed skin lesion, type 1, no evident skin lesion. Type 2, no skin laceration, but only contusion. Type 3, circumscribed degloving. Type 4, extensive closed degloving. Degloving means there is a separation of the subcutaneous tissue from the fascia, of the fascia, and this is gap filled with hematoma and liquefied fat. This photo shows it's open degloving injury with this wound in the skin, and this photo shows closed degloving injury. There is no wound in the skin, but there is bloody vesicles. Type 5, necrosis from contusion of the skin. Open skin lesion, either skin breakage from inside down. Type 2, skin breakage from outside in, but the lesion is less than 5 centimeters. Type 3, lesion more than 5 centimeters with increased contusion and revitalized edges. Type 4, full thickness contusion. And type 5, extensive degloving injury. For muscle and tendon lesion, type 1, no muscle injury. Type 1, only in 1 compartment. Type 3, into 2 compartments. Type 4, in 3 compartments. Type 4, there is a compartment syndrome or crush syndrome. Also, the muscle and tendon lesion, type 1, no neurovascular injury. Type 2, only nerve injury. Type 3, localized vascular injury. Extensive segmental vascular injury, combined neurovascular injury with subtotal or even total amputation. Journey classification. We now talk about the treatment of pelvic fractures. Several options having various advantages and disadvantages have been introduced for the treatment of pelvic fracture, either closed reduction and casting, combined intermodular nailing, complete fixation, open reduction and internal fixation, minimally invasive plate, external fixation, or 2-stage treatment. Despite recent advantage in medical science and technology, the treatment of pelvic fracture has remained challenging. None of the available treatment methods could be considered as the gold standard for treatment of pelvic fracture. This is due to severe injury to soft tissue, high energy pattern of the fracture, and severe edema. Soft tissue injury is an important reference when determining the optimal timing of internal fixation and the surgery and choosing the type of fixation. So we can see this a lot of injury of skin in this condition. The goals of treatment for biological exposure, articular surface restoration, bone graft metaphyseal defect, pattern split fixation, atraumatic closure, early active range of motion, protected with bearing. The reduction is very important, single most important factor for better function outcome. Fracture reduction quality is more important than implant choice for stability. The reduction can be done by direct reduction, through open reduction, or percutaneous reduction, indirect reduction either by calcaneal traction, mobile traction, external fixation, elzaro fixation, or distraction. Like this case, in my case, is only reduction through ligamento-taxis. There is not a single method fixation ideal for all pelvic fracture and suitable for all patients. There is a lot of type of external and internal fixations methods. There is a lot of questions that come to our mind in treating pelvic fracture. If we consider the trauma, we must know the type of injury, either high energy or low energy. According to soft tissue classification, we can choose this algorithm. If the fracture is open, we can do debridement and the application of negative pressure dressing and then external fixation, or closed, we can restoration to the type of fracture we can manage. According to that type of fracture, we have a type A and B, and the type C1, we can treat it through open reduction internal fixation with locking plate using minimally invasive technique. Type 2, C2, and C3, according to, we can use external fixation. According to the type of implant, we have either open reduction internal fixation, or external fixation augmented with minimally invasive technique. The external fixation either by elzaro or monolateral fixation or hybrid external fixation. According to the technique, we can talk about reduction sequence, approaches, and the fibula fix or not, and the outcome. Timing of injury, either timing of treatment, either acute treatment or delayed intervention or staged procedure. Indication for operative treatment: articular step more than 2 mm, valgus angulation more than 5 degrees, any varus, open fractures, compartment syndrome, vascular injury, or polytrauma. A non-operative indication: undisplaced stable type A1 or significant comorbidities, excessive risk with surgery. Surgical timing: we can do either acute intervention or late after 6 days and avoid from the first and 6 days because this bad general condition of the soft tissue. So in this case, we cannot do immediate intervention, so don't touch the patient, or just do traction and do delayed intervention. Acute definitive open reduction internal fixation indication in simple and close minimal soft tissue injury within 1 day of trauma and with experienced surgeon. But the drawbacks: there is a severe skin problems, especially when you use large plates, may further compromise the availability of the bone and damage of soft tissue. Staged management is if there is any skin complication. Indication of first aid stage management for stabilized injury, like this X-ray. Reduce soft tissue tension and management open wound till improved, and then do definite treatment. Decrease severe pain. Why we need the first stage? For allowing soft tissue to settle and further imaging and plan joint reconstruction by either open reduction internal fixation or continue with external fixation. But the drawbacks of the delayed intervention: it's long-term hospital stay, increased risk of infection, lack of anatomical reduction due to delayed operations. The first stage done by either temporary fixation or plus or minus open reduction internal fixation of the fibula as soon as possible, and do ligamento-taxis to reduce the fractures and stabilize the fracture with soft tissue recovery. We can use price in principle, LP like protection, are for rest, as for ice packing, then compression and elevation. Plus or minus fibular fixation for control talus position, which uses posterior subluxation of the talus. After reduction of the fibula, we can see that the talus reduced for normal position. The use of the drawbacks of fibular fixation is complication of the skin, like these wounds. We can use intramedullary fixation of the fibula to avoid this skin complication. Other step for the first aid, early fixation of simple articular component to convert type C to type A, like this X-ray for the restoration of articular surface. Also, early fixation of the simple metaphyseal component for conversion of type C fracture to type B fracture. Why we do early fixation of this metaphyseal fixation? Because later in the second stage, there is a difficulty in reduction of this fragment after removal of the fixator, and it is for interfragmentary fixation of metaphyseal fragment. When you use traction by external fixation as a first step, we must fix the first ray or the medial cuneiform or cuboid bone to prevent procurvatum deformity of the distal tibia, like this photo. So we must need fixation of the first ray. We can use external fixation as a definitive treatment, either in isolation or with limited articular fixation, or interfragmentary screw for the metaphyseal extension, or can use olive wire within the frame of Elizarov, plus or minus fibular plating, and supplemented open reduction internal fixation by minimal or many adhesive plates. The advantage of Elizarov external fixation, it is a circular frame, provide better stabilization, especially in comminuted lesion and with soft tissue injuries. It controls the fracture in all three planes of the reduction. We can use through it olive wire for syndesmotic separation and reduction of articular cartilage, for fixation of the tibial malleolus fragment. Also can even provide a horizontal compression for spiral fracture of the metaphysis or diaphysis. Inclusion of the foot in the external fixation and using as a joint spanning are also possible with the using of Elizarov external fixation. If we compare the result of the two-stage internal fixation with methods with a definitive external fixation, the period of fracture union was longer for two-stage group, but the rate of non-union, malunion, and infection were higher in external fixation group. We can use first aid or the first stage either by external traction fixation, or use a resuscitation distraction frame or traveling traction frame. All these are different method of traction for our ligament axis for this pelvic fracture. The disadvantage, the distal fragment can be displaced posteriorly, as we mentioned before. It is entry point for using the Chan's half pin. When we use Elizarov method for fixation for the management of balloon and the distal tibial fracture, a technique guide, we do the proximal construct of the frame, and this is for foot pieces for the foot, and we have a floating ring in front of these fractures. Then apply the Elizarov. After ligamentotaxis, we can fix the fracture by wires and fix the calcaneus through the foot piece. And we can use distraction for reduction of the fracture. Then adjust the floating piece in front of the fracture fragments. And we can use olive wire for compression of the fragments and reduction of and maintain stability of this fracture after reduction. Then reduce the lateral fragment by this wire. Then decrease the ankle joint distraction after fixation of this fragment by the olive wires. And the final frame reconstruct. Thank you.
Thank you so much, Professor Mohamed Laklouk, for this very interesting talk. We have just one question. Can we do primary arthrodesis from the start?
I'll try first to try to reduction, but if there is extensive injury, we cannot do reconstruction for this fragment. We can do in some cases primary arthrodesis.
Yes, thank you so much, sir. Thank you for joining us, Professor Laklouk. Thank you so much, sir.
Okay.
Can we stop, please, the sharing screen, sir?
Okay.
Thank you so much, sir. Our next speaker will be Professor Ahmed Ramy from Helwan University. Professor Ahmed Ramy is my little brother. Thank you so much, Professor Ramy, for joining us tonight. And sorry for being late. Professor Ramy will speak about the posterior malleolus fracture from another point of view. Now we see the Egyptian point of view, not the UK point of view. Thank you so much, sir.
Thank you, Dr. Mohamed, for your kind invitation and for your continuous support for the process of continuous medical education. As you said, we now try to present the Egyptian point of view for the posterior malleolus fractures. Now I'm sharing my screen. Can you see it? Is it clear, Dr. Mohamed?
Yes, sir.
Okay, thank you. Actually, posterior malleolus fractures are still controversial till now. When we review the literature, we will not find a clear consensus on the treatment, but on the treatment for the fracture, especially that there are many patterns for the posterior malleolus fracture. This is one example of these patterns where we can see here a very small fragment in the posterolateral corner of the distal tibia. And this is another pattern where we can see a larger posterolateral fragment. This is a third pattern where we can see a large posterolateral and posteromedial fragment, and it's more clear here in the 3D view. Our ILO is to describe the indications for surgical treatment for the posterior malleolus fractures. Actually, when we go through the literature, we will find that there was a clear consensus on that a size about 20% or more of the tibial of the distal tibia is an indication for surgical intervention. And it's clear that it's 20% in the lateral UX. However, later it was proven that the lateral X-ray overestimates the articular involvement of the distal tibia if it's compared to the CT, and this study has proven this. These are two examples of two patients. Here we can see the posterior malleolus fracture. It represents about 15.5% of the distal tibial articular fracture, but when we go to the axial cuts of the CT of the same patients, it's only 10.6%. Another patient at 15.5%. When we go to the CT cuts, it represents only 11%. This has led up to the question: is the lateral X-ray is enough? And the answer was no. And this was proven again in this study, where they have studied 160 ankle fractures involving posterior malleolus. And here, in this group, it was representing 57.5% of the group, where they have managed according only to the plain X-rays, while in 42.5% of this group, they have treat the patient according to the CT scan. In this group, only 26.3% of these patients were treated surgically for the posterior malleolus. But in this group, when they have used the CT informations, this group which was treated surgically for the posterior malleolus, it was around 50%. So in the posterior malleolus fractures, the preoperative CT is mandatory. We cannot plan our treatment only on the lateral X-ray. In this study, we have asked another question. Are there any other factors that determine the treatment plan for the posterior malleolus fractures? And the answer was yes. The posterior malleolus fracture is an articular fracture. So the articular surface congruity will affect the final outcome of the treatment and the quality of reduction. And they have emphasized the fact that the size is not an accurate indicator for the treatment plan of the posterior malleolus fractures. And they have raised the principle of fracture configuration. We have found that the fracture configuration will directly affect the treatment plan and the final prognosis. In this study, they have studied the fracture configuration of the mapping of the distal tibia, and we have found that this area, the red area, represents about 70% that could be fractured in the posterior malleolus. And again, for the Mason classification, they have made this clear and simple classifications for the posterior malleolus fractures. In type 1, as we can see, there is a small fragment in the axial CT cuts. This fracture line does not cross through the incisura, while type 2 and type 3, the fracture line cross the incisura here and here. But in type 2, the fracture fragment is only posterolateral in 2A, while in 2B, there are two fragments, one posterolateral and one posteromedial. In type 3, there is a larger fragment that includes the posterior malleolus, and some authors consider it a balloon fragment. In this study, well, they have planned the treatment according to the Mason classification. They have concluded or advised that in type 1, we don't need to do any direct surgical intervention to the posterior malleolus, and we can fix it indirectly by syndesmotic fixation, because we all know that the posterior malleolus is the tibial attachment of the posterior syndesmotic ligament. In type 2 and type 3, they have advised of open reduction, internal fixation, or surgical treatment, generally for the posterior malleolus. Back again to our cases. In the first case, as we can see here, there is a small posterolateral fragment, as we can see, and it does not cross through the incisura. And according to Mason classification, this is type 1, and this is what was done according to their treatment guidelines. There was only syndesmotic fixation. The second case, as we can see, there is a larger posterolateral fragment that the fracture line cross through the incisura itself, and according to the classification, this is type 2A, and this is what was done. There was a fixation, direct open reduction internal fixation of the posterior malleolus using two screws. The third case, as we can see here, there is a large fragment posterolateral and posteromedial. That's clear here in the 3D reconstruction, and according to Mason classification, this is type 2B, and this was treated surgically. I'm sorry for the bad quality of the X-ray, but this is only one that I got for this patient. The patient was treated by a plate for the posteromedial fragment and the additional screw for the posterolateral fragment. So our home message in Mason type 1, we don't need to treat the posterior malleolus itself surgically, but we can use syndesmotic fixation only. It will sufficiently reduce the small posterior malleolus fragment, while in Mason type 2 and type 3, we need direct surgical treatment for the posterior malleolus fracture itself. Thank you.
Thank you so much, Professor Ahmed Ramy, for this very interesting presentation. If we have any questions to Professor Ahmed.
Thank you, Dr. Mohamed.
Thank you, sir.
It's my pleasure.
يعني انا بقالي زمان ما شفتكش يا دكتور احمد، وانت وحشني والله.
باشا انا ببقى مبسوط وانا موجود مع حضرتك والله. ان شاء الله دايما جميعا على خير.
ربنا يبارك فيك.
ربنا يخليك يا فندم.
Okay, we have just one question. Professor Ahmed, what approach do you prefer for open reduction internal fixation?
Actually, it depends on the fracture configuration, but in most of the cases, the posterolateral will be sufficient.
Yes, sir. Okay,
but
thank you so much, sir.
We can see, as we can see in some cases, there are posterolateral fragment and
Another question: why buttress plate? From Professor Amr Azzam. Why buttress plate? Dr. Ramy?
Because Dr. Mohamed, it's intra-articular fracture and it's a large fragment, and I thought that the screw will not be only the only screw will not be sufficient for the fixation of such a fracture.
Yes, we have 2 more questions, Dr. Ahmed. Sequence of fixation in trimalleolar fracture from Dr. Saad.
Look, there is a controversy on this issue, and it's usually according to the preference of the surgeon. But generally, from my point of view, I would like to restore the length of the posterior of the lateral malleolus first, then to attack the posterior malleolus, then the medial malleolus.
Yes, sir. And from Mohamed, what about the lateral approach?
The lateral approach will not be sufficient to attack the posterior malleolar. Remember that you have a small skin bridge between the posterior approach and the lateral approach. So it's better to attack it either posterolateral and posteromedial, or otherwise you will sacrifice the skin.
Yes, sir. The last question is mentioning through lateral approach, through fibular approach, I'm sorry, through fibular approach.
I didn't get it, Dr. Mohamed, please.
Yeah, I think he's asking if you fix the posterior malleolus through the fibular approach.
No, it's posterolateral approach. Posterolateral, through the posterolateral approach, you can reach the posterior malleolus, posterolateral fragment, and the lateral malleolus also.
Yes, sir. Much, Professor Ahmed Ramy. And now we will move to the next speaker. Thank you, sir. The next speaker is my dear brother and my dear friend, Professor Mahmoud Abu Zeid, Professor of Orthopedic Surgery, Banha University. Professor Mahmoud will speak about metatarsal fractures. Professor Mahmoud, please.
Thanks, Dr. Ashab, for your great efforts. And thanks to Egyptian Orthopedic Association, and thanks to EVA Farms. I will try to be sticky to the time schedule. We will talk about metatarsal fractures. We will show 2 items: the Lisfranc injuries and the metatarsal shaft fractures. The Lisfranc injury, the dilemma regarding to the diagnosis of Lisfranc injury. So diagnosis, you should put it in mind as any foot trauma, you should suspect Lisfranc injury and you should exclude Lisfranc injury. We will deal with the diagnosis and treatment of Lisfranc injury. Regarding the imaging, we should have AP oblique lateral views to the foot. We have 5 critical radiographic signs that indicate the presence of midfoot instability. The first is disruption line drawn from the medial base of the second metatarsal to the medial side of the medial cuneiform, as shown in this X-ray. This is an AB view. Secondly, there is maybe widening in the interval between the first and second ray, as is shown in this X-ray. The third cardinal signs, disruption of line drawn from the medial side of the base of the fourth metatarsal to the medial side of the cuboid on oblique view. And maybe we have a dorsal based subluxation on the lateral view, and maybe disruption of the medial column, which is a line longitudinal from the medial suspect of the navicular and medial cuneiform. If we suspect Lisfranc injury and these 5 cardinal signs are not seen in this AP oblique and lateral views, you should have stress and weight-bearing radiographs, and you should have a CT scan to exclude less frank injury. The treatment of less frank may be non-operative in form of cast immobilization for 8 weeks if no displacement on weight bearing and stress radiographs and no evidence of bony injury on CT. You have no bony injury in CT and the loaded food views are normal. The operative intervention in the form of open reduction and rigid internal fixation. The indication of open reduction internal fixation is any evidence of instability more than 2 millimeter shift. And this open reduction internal fixation is favored in bony fracture dislocation as opposed to pure ligamentous injuries. As pure ligamentous injuries, the evidence-based medicine now is regarded to the fusion. Primary arthrodesis of the first, second, third tarsometatarsal joint, the indication of pure ligamentous arch injuries excluded by CT. This is the primary arthrodesis of the first, second, third tarsometatarsal joints with screws. There is a controversy between the screw usage for internal fixation or for fusion or bridging plate in open reduction internal fixation, not for the fusion. Midfoot arthrodesis, we should extend your arthrodesis to the navicular and midfoot in chronic less frank injuries with neglected injuries more than 6 months with advanced midfoot arthrosis and have failed conservative therapy. The metatarsal fractures, the fifth metatarsal fracture most commonly fractures. Third metatarsal fracture rarely occur in isolation as 68% associated with fracture second or fourth metatarsal. Multiple metatarsal fracture lose the stability of intermetatarsal ligaments, leading to increased displacement. So in these cases, multiple metatarsal fractures, even undisplaced, should be fixed. Stress fractures, consider metabolic evaluation for fragility fracture, seen mostly at the second metatarsal in ballet dancers and cross-country runners. The treatment of metatarsal fractures, non-operative treatment in the form of pilon knee cast indicated in first metatarsal non-displaced fractures, central metatarsals isolated non-displaced or minimally displaced, stress fractures. So this indication for isolated central metatarsal, which is non-displaced or minimally displaced. And we will show the next spine what is the level of this displacement. Operative intervention, either percutaneous versus open reduction internal fixation indicated for open fractures, first metatarsal any displacement. Why the first metatarsal any displacement should be operative intervention, as no intermetatarsal ligament support and 30 to 50% of weight bearing with gait. The central metatarsal multiple fractures, multiple central metatarsal should be have operative intervention, even non-displaced. And if there is displacement in sagittal plane deformity more than 10 degrees, this sagittal plane deformity, if dorsal displacement, this will be lead to transfer metatarsalgia to the surrounding central metatarsals. And if it's a plantar flexion, this will be to lead to pressure ulcer and compression sore. If more than 4 millimeter translation should be have operative intervention for the central metatarsal. The base of fifth metatarsal, we can show this slide to show the anatomical parts of the fifth metatarsal with the tuberosity fractures, which is avulsion fractures in zone 1 from Brownius brevis or the plantar rhamponeurosis. The true joints fracture is zone 2. It is opposite to the fourth intermetatarsal articular surface, and the third zone 3, is stress fracture and shaft fracture and hip fracture for the fifth metatarsal. This is the classifications for the base fifth metatarsal fractures. The treatment of the base fifth metatarsal fracture, zone 1, it is a proximal tubercle, non-unions and is uncommon and treated by protected with bearing cast. Zone 2 is a metaphyseal diaphyseal junction involved the fourth, fifth metatarsal articulation. This is a vascular water area. This is increased risk of non-union, so treated by non-wed bearing short leg cast for 6 to 8 weeks, intramedullary screw fixation for elite or competitive athlete. In zone 3 fractures, this is a proximal diaphyseal fracture, distal to the fourth to fifth metatarsal articulation, increased risk of non-union and treated by non-wed bearing as short leg cast for 6 to 8 weeks with intramedullary screw fixation in sclerosis, non-union in or in athletic individual. Thank you.
Thank you so much, my dear brother, Professor Mahmoud Abu Zeid, for this very interesting topic about the metatarsal fractures. If we have any questions to Professor Mahmoud. I think we have no more questions. Professor Mahmoud, would you please stop your sharing screen, please?
Okay, sir.
Okay. Thank you so much, Professor Mahmoud. Our next speaker will be Professor Ahmed Abid from Monofea University. Professor Ahmed will speak about a very important topic, which is complex acetabular fractures associated both columns. Professor Ahmed, you are very welcome, sir.
Thank you, Professor Asha, for your kind invitation.
Thank you so much, sir, for being with us.
I'm sure your tremendous effort all over the day is matchless.
Thank you so much, sir.
I'll go through a complex case of acetabular fracture. My screen is well shown for all of you.
Yes, sir. Yes, sir.
Okay. Most of us face these complex fractures every now and then, and the management of these cases should be in experienced hands because the complications is very disastrous and needs very difficult operations to correct these malunion or non-union in the form of arthroplasty. This is a very difficult situation for any surgeon. This is a 45-year-old man having a road traffic accident. In this X-ray, you will find that the anterior column of the acetabulum is disrupted in the form of discontinuity of the ilioinguinal iliopectineal line, and the posterior column is disrupted in the form of the ilioischial line, and this is a fracture going up in the iliac wing. The posterior wall of the acetabulum is also fractured. Now you can see this CT. This is anterior column fracture. This is a posterior column fracture. And down in the CT, in the caudal view, you can notice a posterior wall fracture. This is a coronal view, a fracture of the anterior column and a fracture of the posterior column. This is a sagittal view, fracture of the anterior column and the posterior column as well. So in this 3D CT, how can you classify this fracture? Is it associated with column fracture or an anterior column with a posterior hemitransverse? This is a very difficult situation because this is anterior column fracture is very high. This is a posterior column fracture, so the both columns are fractured. A huge posterior wall fragment is here. This is looking from inside the pelvis, the comminuted anterior wall, the vertical limb of the anterior column fracture. To differentiate between these two types, this is a very nice review article about the associated post column. Most of the material in this literature is collected from this review article. The associated post column includes a complete discontinuity of the acetabular articular surface from the rest of the axial skeleton. So you will not find any part of the articular surface of the acetabulum connected to the constant fragment attached to the sacroiliac joint. Unlike the associated anterior with the posterior hemitransverse, you will find this fragment, this red fragment highlighted here, is connected to the constant fragment attached to the sacroiliac joint. This is very important because this is the only differentiations between this type of the high anterior column with posterior hemitransverse and the both column fracture. You should look to this fragment if it's attached to the constant fragment or it's completely dissociated from the axial skeleton and attached to the acetabulum. These are the types of the associated anterior column with the posterior hemitransverse. This is a high one, type A, passing through the iliac crest. This is a low one between anterior suprailiac spine and the anterior inferior iliac spine. And this is a very low anterior column with posterior hemitransverse. These are the types of the associated post column. This is a T type, and the more common the Y type. You will notice that the articular surface of the acetabulum in both types is not connected to the axial skeleton represented by the sacroiliac joint. The Y type of the associated post column has a low anterior column fracture and a high anterior column fracture. The low anterior column fracture, the fracture line is between the anterior suprailiac spine and the pubic tubercle, the iliac tubercle. Iliac tuberosity, and the high anterior column has an H-shaped and a very rare one, which is the X type with a fracture line passing through the sacroiliac joint itself. How does this fracture happen? It results from a lateral compressive force transmitted through the femoral head. The femoral head acts as a hammer protruding the joint cavity medial side, and causes rotation of the articular fragments of the acetabulum. In the associated post column, the anterior column is externally rotated and medialized, while the posterior column is internally rotated. So to classify this fracture, you should look at the 3D CT and look for this fragment. This triangular fragment is connected to the constant fragment connected to the sacroiliac joint with the axial skeleton. So this is a very high anterior column with posterior hemitransverse with very large posterior wall fragment. How can you treat these patients? Generally, the more dislocated column dictates both the choice of the approach and the patient positioning. Usually, the anterior column is a comminuted one with a simple posterior column. Therefore, approaching the majority of these fractures should start through the anterior approach. These are your choices in the anterior approach, while ilioinguinal is more familiar. The anterior intrapelvic allows you to give you a great access for the medial fragment or the quadrilateral plate. Followed is an AIP approach with a lateral window of the ilioinguinal approach, with or without ASIS osteotomy. The pararectus is a single incision using the second and third windows of the ilioinguinal and the medial view of AIP. The combined anterior and posterior approaches for difficult cases or extended iliofemoral. The sequence of reduction in the associated post column, you should treat it, start proximally in the iliac wing. In all cases, of course, you should make sure that all instruments or clamps or tools or sets are available. Transvenin in the femoral head to laterally distract the femur to decrease the medialization of the quadrilateral plate. A key fragment, then iliac crest, anterior column, then posterior column, then the posterior wall and sacroiliac joint. Six steps in these fractures. This is from the AO trauma North America. Unlike other articular fractures, in the associated post column start extra-articular in the wing, they reduce the joint. This is the key fragment fixed with a K-wire, then 3.5 millimeter screw. And then holding the iliac crest with this forceps, you can reduce the iliac wing and fix it with preliminary screws or plates. After that, you fix the anterior wall fracture by long screws between the inner and outer tibial of the iliac wing. Then reducing the anterior column first, you can insert screws from this plate to the posterior column here. After that, you fix the posterior column either infrapectineal plate through the AIB approach, or turning the patient prone or lateral decubitous to fix it with a separate approach and separate plate. For the associated anterior column with the posterior hemitransverse, you can ignore the iliac wing. At the first, fixes the anterior column, and then fixes the posterior column with the screws, with magic screws in the posterior column or another plate. Then you can fix the fracture of the iliac wing at the end of the operation. This is a different sequence from the ABC approach. The medial fragment can be reduced by two techniques, either the quadrilateral plate, quadrilateral plate, or this novel technique presented by Professor Mahmoud Abdelkarim 5 years ago, using 4.5 millimeter cortical screws acting as a buttress screws. These are screws through the plate outside the bone to reduce the medial fragment. Actually, this is a very nice tool, very cheap tool. The quadrilateral plate is very expensive. You can use these for the quadrilateral plate fractures, reducing it. Then after that, fixing the posterior column with either screws or through the plate, or a posterior column screw through the lateral window of your approach. After that, the posterior wall fragment should be fixed like this. This is a asymmetrical forceps fixing the fragment, and then perpendicular screw either anteroposterior or posterior anterior to fix this fragment. So back to our patients, what are your options in this case? A lot of options already exist. A single or double approach. Floppy patients or direct supine position, then direct prone position for the posterior approach, ilioinguinal approach for the anterior approach, or AIP, a quadrilateral plate for the quadrilateral fracture, or buttress screws. The posterior column should be plated, or magic screws will be enough. Actually, I used anterior interpelvic approach combined with anterior superior spine osteotomy. I made anterior superior spine osteotomy to give me access to the fragment of the posterior wall that gives me a great access for the posterior wall fragment, fixing it with these two screws. I started by fixing the anterior column, and then fixing the posterior, the iliac wing with these screws, the magic screw to the ischium, a plate for the iliac wing, very high iliac wing. I use the same sequence of associated post column in fixing this fracture. I know it's an anterior column with posterior hemitransverse, but fixing the anterior column, fixing the iliac wing at the first gives me a great opportunity to build my fixation, and then fixing the iliac wing with these two long screws made my life easy to fix the fracture. There are two buttress screws here. They will be evident on this view. These three screws in the pubic body. These are the two buttress screws reducing the quadrilateral surface, and these are two screws for the posterior wall fragments through the same approach. No posterior approaches were done. This is the lateral view of the patient, fixing the posterior fragment with these screws, iliac wing, crest, a long screw for the posterior, passing it down to the ischium. This is an AP view of the patient, and this is an iliac view for this patient. This is the obturator view, reducing the anterior column. This is a screw for the osteotomy. This is the plate fixing the iliac wing superiorly, and this is the magic screw going down to the ischium. To conclude, the management of these complex fractures of the sternum is challenging for any orthopedic surgeon. Correct understanding of fracture morphology and displacement is mandatory. The preoperative planning, including the choice of the approach, the positioning, the reduction strategies, and the sequential fixation provides satisfactory outcome in these difficult fracture patterns. Thank you so much.
Thank you so much, Professor Ahmed Abid, for this very interesting, difficult case. It's a very interesting case, sir. Thank you so much.
Thank you. Thank you.
If we have any questions to Professor Ahmed, we have one question now why operative for no displacement in central fracture?
Actually, the concept of secondary congruency that was published 50 years ago nowadays has a lot of complications on the short term, not on the long term. The patient has a very rapid deterioration of the joint reaction forces, which is very high and leading to progression of osteoarthritis and the shortened liver arm of the joints. The medialization of the quadrilateral plate allows for rapid progression and continuous medialization of the head that will not unite with weight bearing at any level. This should be buttressed from inside the pelvis.
Yes, sir. Another question from Dr. Mohamed Riyad. The point of entry of magic screw.
The magic screw for the posterior column is inserted either through the plate or outside the plate from the lateral window of the ilioinguinal approach intrapelvic. You should use two shots on the C-arm, the outlet view to have a good access for the ischium. This is allowed through the outlet view and the obturator inlet view to have good access for the ischium. Actually, you should put more than two screws or more. One directed to the ischium and one to the ischial spine. Unfortunately, I wasn't able to put these two screws. In this case, I only put one directed to the ischium, but the entry point is through the lateral window and the AIP approach.
Yes, thank you so much, sir. I think, we have another question. Anterior intrapelvic approach, do you find corona morts?
In most of cases, it's found. You should start your every case by trying to find this vessels because it may be very large, leading to profuse profound bleeding. So you should look for it. You can find it in approximately 80% of cases.
Yes, sir. Thank you so much, sir.
Thank you. Thank you.
Thank you for joining us in this very fruitful webinar. Thank you so much, sir.
It was my honor, Professor elshafie. Thank you so much.
Thank you, Professor Ahmed. Thank you so much. And now we move to our next speaker. Our next speaker is my dear friend, Professor Saad Gaballah. Professor Saad is a professor in the Damanhur Teaching Hospital. Professor Saad will speak about infected tibial plateau fractures. Professor Saad, please.
Assalamu alaikum wa rahmatullah.
Alaikum assalam wa rahmatullahi wa barakatuh.
First, I would like to thank our beloved Professor Dr. Mohamed elshafie for his kind invitation and my congratulations for the great success of this mega event. I am Saad Gaballah, the consultant of orthopedic surgery, Damanhur Teaching Hospital. I will present a very short case about infected tibial plateau after open reduction and internal fixation. This X-ray at the time of presentation of the patient show tibial plateau fracture extending to the shaft of the tibia, fixed with double plating. The history of the patient: male patient, 43 years old, non-diabetic, non-smoker, no other medical comorbidities, have a history of tibial plateau fracture 3 months ago, which treated by open reduction and internal fixation, ipsilateral calcaneal fracture treated conservatively by cast. There is a history of post-operative infection, but there is no wound breakdown or wound problem at first. When the patient present to me after 2 to 3 months after surgery, the bone was exposed and the patient had all signs of active infection. Challenges in this case: this patient have active infection, non-union of the fracture, exposed bone, very bad skin coverage, stiff knee and ankle joint, loose implant, and there is articular extension of the fracture. So our plan was to give a chance for the patient for union of the articular component, or to go to hardware removal, debridement, some sort of soft tissue reconstruction or coverage, and elshafie fixator. We decide to remove the hardware and debride the necrosed and the dead bone, do primary skin closure as shown in this clinical photo, and apply elshafie fixator. This is the X-ray intraoperative and the immediate post-operative, and this is the soft tissue and the skin condition intraoperatively. Few weeks later, the patient comes to us with infection. Infection was not subsided. The bone becomes sequestrated and exposed again, and the skin coverage becomes more bad. This is the clinical photo after about 2 months of elshafie application, showing the very bad soft tissue condition and the increased and the exposed necrosed bone. Where is the problem? What our mistake? We think the problem was inadequate debridement. We try to save some bone, not to go for need for reconstruction of bone or soft tissue, so we conserve some dead bone. This was a mistake, a big mistake. Our new plan was to go to segment resection and bone transport. Intraoperatively, we remove all dead, necrosed, infected bone, segment resection about 10 centimeters. There is a gap, soft tissue, bone gap, no soft tissue coverage, intraoperative. What about this gap? Skin defect. Skin defect, we made sure that the bone ends are well covered. Proximal and distal bone end are well covered, no bone exposed, and the gap left open. And we start bone transport gradually to close this gap after consultation of our senior professor. This is the gap, few weeks post-operative, and this is the X-ray with the start of bone transport. Infection was subsided. With bone transport, there is a problem of soft tissue invagination. As the fracture bone ends come close to each other, there is a soft tissue invagination. We take the patient to the operating room, and we do refreshment of the bone ends and removal of invaginated soft tissue. This is X-ray showing complete union of the fracture and removal of the proximal ring, and we leave the 2 rings protecting the regenerate. The last follow-up X-ray showing complete union of the fracture, consolidation of the regenerate, and the clinical photo showing acceptable range of motion of the knee joint after about 1 year of treatment. Message from this case: once infection was diagnosed, aggressive treatment should be started and never wait and see. Another message: adequate debridement is a prerequisite if you need or if you decide to eradicate the infection. Thank you.
Thank you so much, my dear brother, Professor Saad Gaballa, for this very interesting, complex case. If we have any questions to Professor Saad, please. حضرتك دايما مشهور بحالاتك الكومبليكيتد يا فندم.
والله يا فندم يعني احنا
بس هي ما ينفعش معاها الا حضرتك او الدكتور جمال حسني.
بنتعلم من
يعني
سعادتك، بس هو احنا
ربنا
كان
يكرمك.
فيها فعلا هي البيج ميستيك ان احنا try to conserve this dead necrosed bone. يعني احنا حصل جاب حوالي 4 شهور والعيان كان بيختفي ويروح ويجي في براحته يعني، فكان كل ما يظهر بمشكله. فهو فعلا كان من الاول المفروض شلنا كل الديد نيكروزد بون دهوت علشان نوفر على العيان وقت. خدت معانا حوالي 2 شغل يعني، بس الحمد لله النتيجه في الاخر العيان ده يعني كان خلاص يعني خلاص about to amputate his leg يعني، فالحمد لله ان احنا وصلنا لهذه النتيجه.
Yes, we have a very nice question. And what if the patient is a smoker?
In our culture, we can't refuse the patient for smoking. فاحنا يعني هو سموكر او ديابيتك هيبقى فيه مشاكل ديلي وانفكشن وديليد يونيون فاحنا بنفهم العيان ان هو you have to stop smoking. بس we can't refuse the patient. يعني خلينا براكتيكال، يعني مش هيجي مريض وهتقول له عشان انت بتدخن مش هعمل لك، مش هينفع، لازم تشوف له حل. احنا مش يعني احنا بنتكلم على Egyptian experience وليس احنا عارفين السموكينج، واخد بال حضرتك مكتوب في الليتريتشر ان هو انا كانت رساله الدكتوراه بتاعتي عن انفكتد فيمورال نان يونيون، وكان في شابتر كامل على السموكينج. بس هو العيان ده كان ملتزم وما كانش سموكر ولا دايابيتك ولا عنده اي كوموربيدز يعني.
Yes. I think we have no more questions. Professor Saad, thank you so much for being with us, sir.
شكرا يا فندم. شكرا
جزيلا استاذ فاضل.
متشكرين يا فندم.
شكرا جزيلا استاذنا الفاضل. Our next speaker will be Professor Sameh Al-Safti. Professor Sameh Al-Safti is my dear brother. He's a professor in teaching hospital, Shibin Al-Kom Teaching Hospital. He will speak about fracture femur with speed scenario management. Professor Sameh.
Okay, السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
Many thanks, Dr. Mohamed. I know that we are late after this long successful day, so I will present a case discussion only, case presentation. Now it's clear. Wait. كده انا ظاهر يا دكتور محمد؟
لا السلايد مش ظاهره يا فندم.
السلايد لسه؟ حاضر لحظه.
Yes sir.
اوكي. بسم الله الرحمن الرحيم. Fracture femur with speed scenario management. Male patient, 32 years old, RTA, presented by open fracture distal femur gastello grade 2 with a crack reaching articular surface.
السلايدز وقفت يا دكتور سامح.
حاضر يا باشا لحظه واحده. اوكي يا باشا.
تمام يا فندم اتفضل حضرتك.
Presented by open fracture distal femur gastello grade 2 with a crack reaching to the articular surface. This is the AB and this is the lateral, and there is another X-ray for the hip. The hip is free. Here's the articular surface. This is the crack reaching to the articular surface. Debridement was done and the fracture fixed by distal femoral locked plate. This is the X-ray after fixation. We can see the X-ray is good, fixation is good, but we will see the scenario now. How the patient continue. After 2 weeks, the patient had wound collection CRB 96. Wound drainage and debridement cultural sensitivity was done with antibiotic cover, but the patient is still complaining with active sinus discharge. So after 3 weeks, patient reoperated by plate removal and fixation by retrograde nail, femur, and iliac graft. This all outside our hospital. This is the nail, but we can see also defect in the debridement here. You can see this is periosseous reaction. This is periosseous reaction. This also, this is periosseous reaction. So I suppose that is the defect here in debridement, and the hurry up in all operation. We'll see. So we'll still have something new in the story. The infection reactivated again after with 3 sinuses boring pus. After 3 weeks, debridement again, drainage again, and nail removal, then fixation by Elizarov. If we check the Elizarov here, we'll find the Elizarov as an external fixator, not allowed to be for compression or distraction. We can see here that the chance been here. This is from the proximal part, and this chance from the proximal part, and to go to the distal part. And also the reaction here is still present here of osteomyelitis. Unfortunately, after 2 weeks, Elizarov ring became tight, narrow, unstable, and impinged skin due to severe edema and infection. This is the ring for Elizarov. It's more tight on the skin. So Elizarov was removed and debridement through direct anterior approach. Why anterior approach? I don't know. Approach was done with fixation by LRS external fixator. This is the X-ray. Can see also here the rarefaction here, and osteomyelitic here, and also the rarefaction, the periosseous reaction here. This is a photo for the patient clinically, and this is the LRS. This one incision. This is the open fracture from the first, the second incision, the third incision. The patient presented to us by this clinical and radiological photo. We can see this is a patient when presented to us after 3 months. You can see there is a 5 operations were done in 3 months. Why they are hurry, I don't know. Before surgical decision, we need to ask ourselves some question. What is the definition of this fracture? If we think about this, is a second debridement Gastello type 2 or 3A. So blade for this type, I don't know why they are hurry to do a blade. What are the main problem of the patient? The main problem now is stiffness of the knee, infection, is still pouring pus, infection, active infection, non-union, and shortening. Where are the main surgical fault? From my mind, I suppose that the surgical fault here is the hurry up. Why they are quick to do everything, every implant here, from plating to Elizarov to nail to LRS, I don't know. What is the plan for management? This is our plan. How many operative stage you will do? What about expected complication? So our plan, we discuss all steps and complication with the patient. Removal, first removal of external fixator in outpatient clinic, waiting for 3 weeks by posterior slab under antibiotic till soft tissue healing. This clinical photo after removal of LRS. This is our patient. This is the X-ray. Under spinal anesthesia, extensive debridement, extramedullary and intramedullary reaming, removal of all infected tissue. So I need to stress about this point. This point is very important. That point is the extensive debridement. We learned before from our consultant and our professor that if you doubt, pull it out. Means if you doubt at any tissue, you must remove it. Don't hesitate. So shortening of the femur about 3 cm by removal of sclerosed end, suction and irrigation, then Elizarov application. We'll see here. This is the reamer. This is the reamer of nailing reamer. I go intramedullary here from manual reamer and intramedullary down also and up, and remove everything from intramedullary and the extramedullary from periosteal of the bone. You can see with us. This is the debris. This is infected tissue from inside the medulla. This is all from outside and inside the medulla. This is our application of our Elizarov. Post-operative, this Elizarov can allow for compression distraction, and this our target here to compress and distract to activate healing here and deactivated the infection. This is the Elizarov. Acute compression, waiting for 15 days with complete weight bearing post-operative, then distraction, rest compression, distraction, rest compression technique, low accordion technique. Follow up for 2 months by the same program. This is after 1 month. You can see there is no periosteal reaction at all. We remove, and this is a shortening here, and this is beginning of the callus. This is beginning of the callus. This posterior, and this is medial. This is another X-ray after 3 months. This is a callus. Healing and union started by bridging callus, length was regained, infection subsided, all in one surgical stage. After 2 months, this is a complete callus. You can see bridging, huge bridging callus. After 2.5 months, this is a callus. This is a photo for the patient with the application of the Elizarov. And this is the last X-ray after removal of the Elizarov. You can see here, this all posterior, here complete healing, here complete healing, and from the medial side. Thank you very much.
Thank you so much, my dear brother, Dr. Sameh Al-Safti, for this very interesting, complex, disastrous case. Thank you so much, sir. I think we have questions to you, Professor Sameh.
Okay.
No, he is just thinking. Thank you, sir. I think your message from your case, sir, we don't rush in the management.
Yes,
wait and see.
yes.
Don't rush in the management.
This is Gastello 3A, so we can wait for we can wait with a posterior slab to be assured that this patient has no active infection or impending infection. This patient outside the road, so we can suspect anything to happen. Like in the second day, put a plate. Reduction is good, like in put a plate in the second day. So this plate and the hurry up and remove after 2 weeks, and after 2 weeks, the second stage and third stage, all in 3 months, 5 cases. This cannot be, I cannot imagine 5 operations in 3 months. I must wait for 3 weeks and 3 weeks and 3 weeks and do CRB and septic profile. And after that, I can do my Elizarov or external fixator or definitive treatment.
Yes, sir. The main thing I have to consider in this speed scenario is the soft tissue condition.
Yes.
What about the soft tissue condition?
The soft tissue is good from outside. Like from inside, when I open and the debridement, all soft tissue inside is a little bit sclerosed bone and gangrenous muscle around the dead end.
Yes, sir. Thank you so much, Professor Sameh, for this very interesting, complicated case. I think we have a question for you, sir. I'm sorry.
Okay.
Dr. Dorgham is saying, I like it all in one step. Thank you, sir. And Dr. Mohamed is asking, would you consider all impregnated intramedullary nail after stabilization with external fixator after you decided this way of management?
Yes, I'm with him. I discussed with the patient many plans, plan A and B and C. Plan A, cement spacer and impregnated cement spacer for this 4 centimeter or 6 centimeter and another X-fix. He refused X-fix. He refused completely X-fix. I discussed with him impregnated nail, and I do many cases from impregnated nail, but I found that the impregnated cement nail with antibiotic have no cannot help you in compression distraction technique. The Elizarov alone can help you in compression distraction technique. So you cannot regain length by this impregnating nail, and you can find another sinus or another non-union. So the rate of non-union with Elizarov is little bit more little than impregnated knee. I'm with him, that is option, but I choose the more complex option to do everything.
Yes, and one of our attendees asking about the antibiotic. What about the antibiotic?
Yes, I start by umbrella of antibiotic broad spectrum, and then I took all soft tissue and bone in and do histopathology and culture for antibiotic. The antibiotic I remember that is vancomycin. Yani it's sensitive to vancomycin. I remember it.
He's asking also about antibiotic septal beads. No.
These days, these years, I didn't try to do anything for that. And there is a
Indian
new
session.
thing.
In the Indian session, I asked the Indian professor about the same topic, the antibiotic impregnated beads, and he's also said I don't like it. Yeah.
Yes.
Yeah. Thank you so much, sir. Another question. I'm sorry.
No
what about muscle? Oh, yeah.
Yes, I told you before. I told them before that that option technique, cemented spacer and muscular technique, and after that you will do elzarov or definitive fixation. I prefer elzarov.
Yes, sir. Thank you so much, sir. Thank you so much. Now we come to the last speaker, Misk al-Hatem, my dear little brother, Dr. Ahmed al-Sheikh, one of the eminent stars in Liverpool and in Banha University in the elzarov and deformity planning. Professor Ahmed will speak about soft tissue consideration in open fractures, a very important topic. Professor Ahmed.
شكرا جزيلا. السلام عليكم.
السلام ورحمة الله وبركاته.
Thanks so much, Prof. Ashab, for this really successful and long day. And sorry for my voice too, I had some flu recently. So it won't be long after all this fruitful day. I will just put some light on the soft tissue aspect of open fractures, some of the basics, and just one case presentation. Mohamed al-Sheikh, lecturer for orthopedics and surgery, Banha University. So in major trauma, we always think about the patient at the beginning, then we think about the limb. So for the patient, we do the ATLS. Pain management, the first line will be intravenous morphine, second line will be ketamine. Of course, other non-steroidal anti-inflammatory can be used also. The antibiotic in open fractures is very important thing. And in recent guidelines, this should be started even in the ambulance before the patient getting into the hospital. So it should be ASAP, as soon as possible, within 3 hours. And the antibiotic choice, of course, will be according to the local guidelines. Here in Egypt, we have this national guidelines for antimicrobial prophylaxis in surgery, which suggest giving in type 1 and 2 open fractures, cefazolin, which is first generation cephalosporin, clindamycin if the patient is sensitive. And for type 3 or type C, you give ceftriaxone, which is third generation cephalosporin, and if sensitive, you will give clindamycin and levofloxacin. Of course, there is still some space for adjustment according to local policies in local different hospitals across Egypt, but this is the national guidelines. Again, the abdominal and chest injuries, we do the EFAST, extended focused assessment with sonography, whole body CT, which is a rapid scanning. If it's available, it will save some time for the patient. Intravenous tranexamic acid is a very important thing that should be kept in mind, especially in the first 3 hours. It has a proved effect in reducing the blood loss and improving the patient outcome. There may be some controversies about using it in multiple injured patients, but at least for a patient with single limb injury with open fracture, you can do tranexamic acid safely. The reverse of anticoagulant agent, that's another important thing if the patient has already on some of these, so you start to think about giving android if you need it. Fluid replacement, of course, you do the plasma, red blood cells, 1-to-1 or whatever the ratio according to different schools. Interventional radiology, if you have some like pelvic injury and bleeding inside, interventional radiology would be one of the things. Heat loss prevention is a very basic thing, but it's overlooked in many cases. So you keep the patient exposed while doing the x-rays, while doing the slabs, and then the patient lose some height. And hypothermia is one of the triangle of death, if you remember. So we need to keep the patient away from hypothermia and decrease the heat loss. Do the fracture splintage, and then we start to look after the limb itself. Should we go for damage control, or can we do the definitive care? Adequate resuscitation, which is evidenced by good urine output, by serum lactate level, which is the most sensitive indicator, and gastric mucosal pH, if this is available in your hospital. Otherwise, you can use the base deficit, which is blood sample, and then you have a range from -2 to +2. If the patient has these three, so the patient is adequately resuscitated, and then you can go for a bit lengthy operation. That's the whole point. Otherwise, if the patient is not adequately resuscitated, you have to look into something that is very fast and then very concise. Many things have been described to differentiate between the patient that should go for damage control or definitive care. But apart from this, the open fracture itself, what about the main things around it? So on the basic level, for all the residents on the ER, please do not irrigate the open fractures in the emergency room. But what is the details of this? What we mean that you can do social wash of the limb because of the overt dirts or whatever. But the open fracture itself, it has a very different scenario because irrigation of the open fracture, in most cases, it pushes the debris inside the wound, and you cannot just wash it like you wash a plate. No, really, that's very different because all the dirts will be sticky to the tissues or sticky to the bony ends. So you can do the social wash, but the proper irrigation, this should be done in the theater. So that's number one. Number two, you remove the gross contamination in the ER. You do photographic documentation, which is very important to decrease the exposure of the wound. You will hand this photos or you talk to your consultant, and then if he comes over, he would like to have a look, and then you open the wound again, and then for everyone who's trying to assist the patient will have to open the wound again. So that's a risky thing and increases the risk of infection. So you have to do good photographic documentation. And after that, you just had dressing, saline soaked, and then occlusive layer with like a film coated or whatever. The main question, when should I do the debridement? So normally, in most cases, we'll say do elective formal debridement in theater, which is next day morning list. Again, this is the most recent evidence because for a number of years, we have been are surrounded by the 6 hours limit. So you need to do the debridement in the first 6 hours or whatever. But then over time, the evidence evolved that 6 hours, 24 hours does not make a difference, except in some scenarios, like the gross contamination, which like the open wound, and you can a lot of dirt, a lot of dust, compartment syndrome, vascular injury, or multiple injured patient. So you have to judge any of these things. If one of these things is available, then you will go in a bit of rush to do the debridement, maybe in the middle of the night. But otherwise, for grade 1 open fracture or a puncture or whatever, you don't have to do it in the middle of the night. Do it in the next day list where everyone is in his perfect mood. So what are the prerequisites of the debridement? So the first thing, it should be done jointly, which is the orthoplastic approach that has been mentioned by many speakers. The last was Prof. Fadel. And this is very important thing. Having a plastic consultant working along with the orthopedic consultant provide the best care for the patient. This evidenced to decrease the hospital stay, improve the outcomes, decrease the infection, because the plastic surgeon can do the soft tissue cover or can deal with the soft tissue defect, whatever it is, on the first stage. The old fashion of doing some of the orthopedic job and then refer to a plastic surgeon, it turns out to be time-consuming, more possibility of infections, and of course, lengthy duration. So this should be done jointly. Do the social wash again, sterile tourniquet, wound extension. This will be done by the plastic surgeon along with the fasciotomy lines. We are talking mainly about the tibia, as this is the most common open fracture that we have. And then the one main thing about debridement. Debridement is not a wash. It's not scrapping. No, it's 3-dimensional debridement. So you cut the skin and dermis till it's bleeding. You cut the bone till you can find fabric sign. You do the tuck test for the bony fragments, which just pull it up. If it comes out with you, don't return it back. This is a dead bone. This is needed for infection. And this is one of the most common factors for infection of open fracture, that you leave completely denuded bony fragments. This is different if we are talking about articular fragments. Articular fragments are very precious. Even if they are disconnected from soft tissue, you still put it back. Do high pressure lavage. Again, this is some controversy, high pressure or low pressure, but whatever, you will do a massive wash after doing the debridement. So the aim of the wash to decrease the bacterial load, not to clean the tissues. You will be cleaning the tissues by cutting the dirt off the tissue. That's a very important thing. You are not doing the wash to clean the tissues, just to decrease the bacterial load. And then at the end, you will classify what type of fracture that you have. So Gastello 1 or 2 or 3 and 3A or B and C. This is not in the emergency room. This is not when you look at the patient for the first time. This is done after doing the debridement. And then you will find out that you have 1 or 2 or 3 and whatever. Compartment syndrome, just this is a red light that all of us should be looking at. It's an evolving event. It's not one-time diagnosis. So you will see the patient, you find some tense cough, you find some passive pain with passive stretch, and then leave it for 30 minutes, 60 minutes, re-examine, and you will find that these things are getting worse. It's an evolving event. Once it started, it will continue. Sorry for that. And then the clinical diagnosis of the compartment syndrome is the mainstay. Unfortunately, we don't have anything that is evidenced to give you a precise reading. You can, of course, do the intercompartment pressure, but again, it's not precise, and there are many mistakes around this. So it's mainly a clinical diagnosis. Do the monitoring if it's available, and the standard that if the difference is greater than 30 millimeter mercury, then you go for fasciotomy. These are the fasciotomy lines, very standard, very basic thing that everyone should know about it. The medial side, which is about 1.5 centimeters from the medial border of the tibia, then you can go for the posterior compartment, the deep and superficial, and the lateral, which is 2 centimeters lateral to the chin of the tibia, and then you can go for the peroneal and the anterior compartment. Here is the only case presentation that I have today, which is just to see how to think about such thing. So this guy, 20 years old, had this crash, and we can see the degloved skin over the heel and massive laceration. Unfortunately, he has good motor and vascular supply. Then he had some surgery at the hospital that he has, and this is again one of the things that you just the previous talk, that you have to make the good decision for the patient. They do some debridement and then just put it on some sort of vac, and then this is after a while. They did some shortening to have the soft tissue closer, and he has this segmental fracture. But again, even after 3-4 weeks, you have the wound that is not fully healed. This skin is almost dead, is pouring pus. So we have to do some massive work. The issue about this area that it cannot be covered by local flap, and it's far away from the gastrocnemius flaps. So the options will be either a free flap, which will incur morbidity site complications also, and it may work or it may not. There are some failures of it. So we started with the debridement. So we removed the plastic surgeon removed all the tissues. You can see the extension here through the fasciotomy line, and then he was happy at the end by all the bleeding fresh tissues. And then we closed this, we'll put some fixator and leave it for about a week or so. So what about the second stage? So we have discussed the free flap versus cross-leg flap, and we went for the cross-leg flap. This is Prof. Gawad, my consultant plastic surgeon. And the cause that we chose this because it's more predictable than free flap. The blood supply is really wonderful in this sort of flap. Of course, the position is a bit difficult for the patient. He will stay in this for about 2 to 3 weeks, and then we will go to cut the skin in the third stage. So you can see here, this is only after about 20 days. You can see full healthy tissue. It's really quite good at it encloses the whole area. So we put our frame, which is full frame. We had the docking site here, which is okay. We had the segmental fracture at the middle of the tibia. We will use it as a corticotomy because he's about 3 centimeters short. So this is the x-rays, this is the docking site, and this is the fracture at the middle. in about a month's time, so we had lengthened about 2.5 centimeters. He had equal knees, he had equal legs, and the soft tissue here. So you can see that even the hair is growing on this flap, which is fully taken, and the patient is really mobilizing very well. So in the key point in this case that the soft tissue cover should be restored. We need well vascularized cover, because that's the point. If you continue doing the VAC, it may close, but again, the VAC will just give you granulation tissue that is very thin, and it does not offer blood supply to the bone inside. Well vascularized cover, which is a free flap or prosthetic flap or any kind of flaps, give blood supply to the bone itself. This reduces the deep infection and helps the bone union. Several techniques. You good to have a discussion with your plastic surgeon, and also counseling the patient, because that's very important. If the patient is not willing to have such, then we go for another option. Joint surgery, orthoplasty, and open fractures is a key point to success in such cases. Thank you so much.
Thank you so much, Professor Ahmed Sheikh, for this very interesting case presentation. We are with 2 questions. I think the first question was to Professor Sameh. What about collagen sheets? I think in Professor Sameh case.
Yes. Yeah. Okay. It can be done. Yeah, you can do whatever you like. I will add another option, which is calcium sulfate stimulant. Of course, you can do it after you ream the femur up and down. You do the billets, and then you put them inside and put them in the wound. So there are many antibiotic delivery systems that can be used in conjunction with the main treatment.
Yes. Another question, Dr. Ahmed. Another alternative of cross-leg flap.
A free flap. This is the second thing, but the free flap, you have to deal with the logistics of doing the free flaps, the lengthy operation, possible occlusion of the artery, and failure of the flap. So after discussion with the patient, he opted for the cross-leg flap as a more predictable and no morbidity site, or not no morbidity site. Of course, there is morbidity site from the anterior thigh, but again, this is different from having a muscle from the back. So, but of course, free flap is a valid option.
Yes. We have a question from Dr. Mohamed Riyad. If soft tissue is postponed, so for how much time soft tissue coverage can we?
That's a very good question, really, because in the guidelines, you can do the flap very early and do even internal fixation, which is the fix and flap technique. Otherwise, if you will go for a late coverage, internal fixation will be risky. During this time, you will have to do the keep the vac on, just to keep everything healthy and to protect the open fracture site. And then for myself, after 2 weeks, I wouldn't go for internal fixation. I will just continue with the reserve.
Yes, another question from Dr. Ahmed Najid. Vac dressing is effective?
Yes, it is effective, but the major problem about the vac that it grows only granulation tissue. You try to open a wound that has been healed with vac, and then you will appreciate what I'm saying. It's a very thin 2 to 3 centimeters layer. It cannot withstand injury. If this patient has small scratch, you will find that the bone is just in front of you. If you open it, it will be very difficult to close it. It's not a very well vascularized cover. I totally agree with you. They have done it for the first few weeks with this guy, but again, this in his case was not enough to achieve this.
Yes. The last question: what about supramalleolar rotational flap?
The excursion of this is very, very small. In this guy, all the perforators really has been already down by the injury itself. So there is no local rotational flap from the distal tibia, and any rotational flap from the occipital tibia, of course, would not be effective.
Yes, we have 2 more questions from Dr. Mohamed Abu Zeid. Good work. Who did soft tissue coverage? Orthopedic?
Of course, the plastic. That's the point. You know, when you see it, you can say, I can do it. It's easy. But again, no, just keep your work to the bone, and then keep the soft tissue work for the plastic surgeon. That's the whole point. The joint surgery makes you go through these difficult cases.
Yes. Dr. Ahmed, I think we have no more questions, and now we come to the end. Alhamdulillah, 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 alhamdulillah. After 3 months of continuous hard work to prepare this international trauma webinar, 13 hours of continuous lectures and educations from 48 speakers from 4 countries, and more than 1,500 orthopedic doctors registered, we come to the end. Finally, I would like to thank all our speakers from all over the world, 31 Egyptian speakers, 10 from India, 7 from UK, and 1 from Ireland. Alhamdulillah Rabbil Alameen. Many thanks to Eva Pharma Company, my dear friends, Dr. Michael and Dr. Mina, for being with us for 13 continuous hours. All the lectures are registered and recorded and will be in a very short period from now on the YouTube channel of the Egyptian Orthopedic Association. نسأل الله سبحانه وتعالى أن يتقبل منا وجزاكم الله كل خير، وإن شاء الله نراكم على خير جميعا، وشكرا جزيلا أساتذتنا الأفاضل. شكرا. الحمد لله رب العالمين. تصبحوا على خير.